Good morning once again, ladies and gentlemen. Welcome to day 3 of the our health summit. If I can kindly ask the folks that are still at the dining area to please make your way in. Our presenter is already connected with us. We're going to do a quick raffle draw. We have time for just one. And while we wait for the rest of the participants to make their way in. Thank you.
So the price for this morning is a one clear backpack with $20. The lucky number is 669314. 669314. Going once, 314. Going twice, 314. 314. Next number is 669304. 304. Going once, 304. Going twice, 304.
I'm sorry, there's no winners yet. We are running on time, so yes. Do keep your tickets. Remember, we have that grand prize ticket, a round trip ticket to either Guam or the Philippines. Okay. Want to take this opportunity to thank the previous days' presenters and guest speakers. Again, welcome to day 3, the final day of our health summit. We welcome everybody and thank you for being here. Just a couple of quick announcements. If you look at your schedule, the 10 o'clock and the 11 o'clock plenary sessions, we made an error and said the venue will be the college. The correct venue will be here at the National Gym. So the morning plenary sessions at 10 and 11 o'clock will be here, not at PCC. Okay, there will also be a hospital tour at 4 o'clock later this afternoon. For those who are interested to go on that tour, please sign up at the registration table, and there will be vans that will be transporting people to that tour. Our first presenter this morning is Kim Conway. She is the lead at One Health, California department, and she will give us a talk on One Health initiative. Hello, Kim. We're ready whenever you are.
Okay, great. Can you hear me?
Yes, we can hear you fine.
Great, thank you. All right, hello everybody. My name is Kim Conway and I am the One Health lead here at the California Department of Public Health. You'll see my slides in just a moment. Okay, great, thank you. Well, I just wanted to thank you all for giving me the opportunity to talk about this exciting topic of One Health. I really wish I could be there in person. Everything I've read about Palau sounds so beautiful, including Jellyfish Lake, which you can see I've included a picture of next to our own Lake Tahoe here in California. And I included this picture because I think both of these places really encompass some of the most beautiful examples of One Health, where you have these natural environmental treasures with unique wildlife that attract people to really appreciate how all three entities can peacefully coexist. So this morning we'll talk with a very brief overview of what One Health is, in case there's anybody in the audience who may be hearing this concept for the first time. Then we'll talk a little bit about going from the idea or concept of One Health to actually operationalizing it or using it and putting it into action. And then I'd like to share some of my plans for bringing One Health to California. And I pulled some pieces and some anecdotes that I hope will be helpful for you all in Palau. And then we'll recap with some key takeaways from the presentation. So I just wanted to start by including this expanded definition of One Health. I know this is a lot of text on one slide, but I've kind of highlighted the key parts here where you can see that One Health is really an idea or approach that seeks to optimize the health of people, animals, and our shared environment. And it really recognizes that all three entities are closely linked and interdependent. And it really prioritizes and values working together to foster well-being and bring different multiple sectors and disciplines together. So health of people, animals, and the environment, they're closely interlinked. And we really want to seek collaboration between multiple sectors to address some of those complex One Health issues. These are just a few examples of some global One Health issues we're seeing all across the world. Zoonotic diseases, antimicrobial resistance, climate change, biodiversity and conservation, including wildlife, emergency preparedness, and food safety and security. Now, I have to admit, when I was asked to speak at the summit, I was really excited because I love One Health, but I was also a little bit nervous because I realized that One Health in California is going to look very different than One Health in Palau. And just to highlight some of those differences, I pulled some of them together on this table while I was doing a little bit of research on Palau. So you can see that one of the most dramatic differences is the size of Palau in California. I've read that the population is about 18,000 in Palau compared to 39 million here in California. We also have some pretty stark differences in our climate. You guys get about 5 to 6 more times annual rainfall than we do. We're pretty parched here in California, and our temperatures tend to be a bit different. I've read that you tend to be a little bit more temperate climate year round, where here in California, our summers are quite warm and our winters are quite chilly. And our land availability really drives the different agricultural products that our nations produce. So here in California, we have a lot of open land that we use for vineyards to grow grapes and orchard for nut trees, and a lot of farmland. We have a large agricultural industry here in California with a lot of dairy operations, where I've read that in Palau you have things like coconuts and sweet potatoes and cassava, which I had never heard of nor tried. And then also some of these differences are driving the natural disasters that are the biggest threats to our nation. So with your heavy rainfall and island territory, typhoons are things of more concern for you all, where here in California, we are so dry, we're seeing wildfires, sometimes multiple each year. And all of these differences between climate and geography are really contributing to the differences we're seeing in One Health threats. So with a lot more rainfall, you're going to see a higher prevalence of mosquitoes. So you'll have a higher prevalence of vector-borne diseases like dengue fever in Palau. And some of the effects of climate change will be seen more notably with things like sea level rise in an island nation. Whereas here in California, in addition to dairy operations, we have a lot of poultry, egg laying, and meat bird operations. And we've unfortunately been dealing with a large avian influenza outbreak. And then, if I haven't mentioned it already, we're quite dry here. I think we've been in and out of a drought pretty much since I've been born here. So what can I offer from California that's going to be of anything of value to you all in Palau? Well, to answer that question, I just want to tell you a little bit about myself and my current role, because I want you to know where I'm coming from as I give this presentation. So as a veterinarian, I've been involved in multiple issues relating to One Health. Some of these activities have included researching environmental drivers of wildlife parasitism, responding to 2 separate avian influenza outbreaks, evaluating the human-animal bond, building a new veterinary clinic for pet owners who are experiencing homelessness in our community, and providing care to animals who have been evacuated due to natural disasters such as wildfires. So while you could say that these experiences have given me a pretty solid understanding of the importance of One Health, my current role is brand new. As the California Department of Public Health's first One Health lead, I have been tasked with this exciting but also daunting challenge of creating a One Health task force and bringing a One Health approach to California. And even with over 9 years of experience working on separate One Health issues, the concept of broadly applying a One Health approach to a government setting is brand new to me. So I say all this to tell you, I'm right there with you. While we all have different backgrounds and experiences, you and I are in the same boat trying to figure out how to really bring One Health to the place that we call home. And what I can tell you is in my current role, I have spent a lot of time thinking and reading and researching what it really means to do One Health. And I can confidently tell you there is no one way. There's no equation or standard operating procedure, unfortunately, for how to do One Health, because the very nature of that would kind of defeat the purpose. One Health should be specific to the issues that your nation is facing, using the specific resources that you have available. But with that being said, there are some international experts who have been in the One Health space for a long time who have gathered over the years to discuss this very topic of how to take One Health from theory to practice. And acknowledging that there cannot be a one-size-fits-all approach, there are some overarching themes that can be applied to any group seeking to implement a One Health approach in their work. So that is what I'd like to share with you today. Through my months of searching about how to do One Health, I pulled some of the pieces that have really resonated with me and empowered me to think, I can do that. And my hope is that by sharing these with you, it will empower you as well. So some time ago, some One Health experts across the world got together and identified what they consider some critical steps in attaining their One Health goals. And I've listed some of the ones that have resonated with me here. The first one is training, and this could be developing a One Health training curriculum or identifying opportunities to integrate One Health approaches into existing curriculums, essentially just building skills within a workforce with the intention of developing a workforce comfortable with the idea of collaboration, who understand the interconnectedness of animals and people in the environment. The second one is a One Health global network. This would just be garnering international support for global collaboration on One Health programs. The best advice I can give you for this piece is, if you haven't already gotten involved with the One Health Commission, I would highly recommend doing that. They are an excellent resource on their website. They've got maps of everyone who's who in One Health in different countries and states, and contact information for people who are leading One Health efforts in their country. They send out monthly newsletters. Pretty much everything going on globally in the One Health space is there. And it's a fantastic resource. The next one is Information Clearinghouse. And this is just creating a centralized area where One Health success stories and lessons learned and resources are gathered and stored. So this could be a file or a web page or an archive in a department, just somewhere so people know where exactly to go if they want more One Health resources or information. And the next one I think is really important, conducting a needs assessment. So this would be developing a country-specific self-assessment where you're really looking inward and trying to identify areas that would benefit from a One Health approach. So asking yourselves, what are some complex health issues that you're dealing with that currently would require collaboration among different sectors? And the next one is capacity building. So this would be identifying ways to leverage existing programs. And one example I found of this was in the country of Sierra Leone. They have these animal health clubs. And these came about because they have very little resources in terms of medical professional staff and veterinarians, and they don't have enough to serve their very large population. And so this was a community-led effort where schools and community members are coming to embed One Health ideas into school curriculum and even teach some of these ideas to children in their own homes. And this is a great way to empower school children to kind of promote that local ownership of One Health and introduce it at a young age to encourage One Health work in their communities down the line. And then lastly, this idea of proof of concept. This is gathering evidence that the use of One Health interventions has led to better health outcomes for people, animals, and the environment. And this could be just finding examples where different groups or sectors have worked together to solve a problem that led to a favorable outcome. And just documenting and sharing those success stories will really encourage others to work together as well. So those were kind of some critical steps that they identified at the large international level. But operationalizing One Health is going to look much different at the state or the territorial level. So I wanted to share a little bit about how I'm applying these concepts to what I'm starting to do in California, starting with my initial starting point. So my very first step was just identifying existing resources. There's information out everywhere I look, and so I'm kind of in this information gathering stage where there have been a lot of One Health efforts globally and in other states, and I don't necessarily need to reinvent the wheel. I'm just trying to grab my hands on everything I can, new publications, new working groups. If there's a seminar or a call, I'm calling, can I join? Just trying to compile all this information and see what's going on in the One Health space. I also recognized my own limitations. I am a veterinarian. I'm not a research scientist or an environmental scientist, but I know that our One Health issues are environmental at their root. And I also know that historically this pillar has been a little bit underrepresented in the One Health space. So I needed to spend some time educating myself on environmental drivers like climate change and chemical contaminants. And then I really spent some time trying to figure out what does One Health mean to me and what are my priorities as I kind of launched this initiative in California. And as I look at different One Health efforts, I'm noticing there's a lot of focus on hunting down the next new pathogen or responding to outbreaks, which is certainly important, as we all saw with COVID. But there's also a lot of things that are already good. And California and Palau are beautiful places. And that beauty is still there because something is working to keep it that way. And I kind of like that perspective of wanting to protect those things, not just continue to fix things after they go wrong. So really kind of shifting my approach to prevention rather than response. And then I came across a new perspective or a newly formed collaboration, perhaps saved time and resources. And that really resonated with me. I feel like these are areas where small changes can really make a big difference. And then lastly, we have, unfortunately, many health inequities in California. And I'm lucky enough to be working for a department that values healing and teaching awareness about inequities. So I'm making sure that I understand that for some of the One Health issues we have, there's going to be populations that are disproportionately affected. So after I did a bit of researching and soul searching, I've started to implement some of these plans, and you can see that some of them are paralleled with some of those critical steps that we talked about earlier. So I'm currently in this kind of increasing One Health visibility stage, and I'm doing this through a number of ways. I'm offering presentations or trainings to different centers or branches within our department just to kind of spread awareness about One Health, but also let them know that I'm here and I can be used as a resource and try to empower them to incorporate a One Health perspective in the work that they're doing. I've also been developing these One Health newsletters that I've just been sending out to different key contacts within my department and also other state partners Sometimes these just include links to new One Health publications, but also trying to highlight some of our own success stories and encourage kind of collaboration by showing examples of when that was really successful for a problem we tackled in California. And then building relationships is a huge part of what I'm doing, kind of establishing my own One Health Global Network here in California. And then we really want to enhance our web presence. So we're going to be working on getting our own little information clearinghouse up as well. As I mentioned, initially I was just kind of compiling all the existing resources that I could get my hands on. And so now I'm kind of going through all those, assessing them and evaluating them for applicability for me in California. And if I'm reading something that really resonates with me or stands out, I'm reaching out to the groups that either published that toolkit or gave that presentation and just trying to set up meetings and get to know what worked well for them and establish a relationship with them as well. And then one approach I'm really trying to take is to encourage people that they don't have to do more work to do One Health. I'm trying to meet them where they're at and ask how I can help. So rather than saying anybody needs to do this or they should be doing this, I'm offering myself as a resource. If something comes across my desk and I see that, maybe only human and environmental health are considered, I'm reaching out and saying, hey, can I offer this animal perspective? And also I will do the work. And usually that's a little bit more well received than asking someone to do something. So in my next steps, I will be launching a needs assessment here. And I'm gonna start by doing that by hosting some informal focus groups with some of our partner organizations like our Department of Food and Agriculture and Fish and Wildlife and our Environmental Protection Agency, just to kind of make sure I can hear their voice on what they're hoping to get out of a One Health approach, maybe where they see there's a need, what resources they have, and what they'd like to see moving forward. And then I'll be using that information to create a One Health task force. And so this will kind of start with a small core working committee where we're going to develop, a mission statement and a vision and set objectives and regular meetings just to create this dedicated time and space to talk about One Health, with the goal really being to enhance our state activities. And then we also plan to expand this to a more didactic or educational group statewide, where I can engage with local health departments, universities, private practitioners, anybody interested or doing One Health activities, just to kind of create a place to come together and communicate. And then lastly, I'll be doing some outreach to our local health departments, youth organizations, some groups that may not have heard much about One Health, particularly some other allied health professionals like pharmacists and nurses who may not have gotten much education about One Health in their training curriculums. And then lastly, I just wanted to share some challenges that I'm facing right now. The first one is that I'm starting from scratch. There's no statewide One Health effort in place. I'm literally at square one, meeting as many people as possible, getting to know different groups. There are some individual One Health efforts throughout the state at different counties and universities, but there's currently no centralized or unified approach. Another problem I'm facing is that my department is siloed and really the whole state is siloed, meaning we have, human health and animal health and environmental health, and they work separately. And agencies have different mandates that direct their activities and different privacy and information sharing practices. So there's many steps and people and levels that need to be navigated through to try to collaborate with everyone. And I'm hoping that my position can be seen as a liaison of sorts, where I'm a trusted and approachable source for collaboration, but I am still kind of navigating those barriers. California is really big. We have 58 counties, multiple statewide agencies. Trying to launch a statewide initiative is really challenging with so many different players. And when I talk to different people about One Health and I approach different groups, most of them are interested and understand the value, and that's been really encouraging, but not everyone is buying in, and I'm learning to be okay with that. Again, like small changes are making big differences, and that's okay. And then lastly, I am just one person. I have high hopes and a lot that I want to accomplish. And I'm trying to remember that change takes time and just focus on one thing at a time. And thankfully, there are many supporters of One Health in California who want to be a part of it, but they are going to be limited in their participation as they have other primary job duties. So how does all of this apply to you all in Palau? So I want to start off by saying that the One Health priorities for me are not going to be the same One Health priorities for you. So really embrace those differences and reflect on what aspects of One Health are going to be the most important to your community, because certain cultural and societal values are going to be an integral part of your One Health success. I would argue that you're probably already doing One Health in some capacity. The very fact that you're having the summit and bringing so many different sectors together and wanted to bring in a One Health presentation shows that you've already acknowledged that One Health is important, which already puts you ahead. I've also read that smaller nations with limited resources may be more successful in implementing One Health programs because it already forces sectors to kind of work more closely together without some of the barriers or rigid public health structures that I'm currently navigating in California. So if that applies to you, great, embrace that. And then with limited resources, relying on the community is key because ultimately it's your community that's going to be affected. I recently read on the Koror State Animal Shelter Facebook page that a young elementary school gentleman collected bottles and cans and donated the funds to your guys' animal shelter. That is amazing. It's like a little One Health champion already, collecting things to better the environment and taking those funds and putting them towards the betterment of animal health. I think that's incredible. It says to me you have an incredible community, and I think they're going to be such a great resource for bringing One Health to the nation. And then lastly, I hear a lot that I don't have time to do One Health, or I'm already so busy, we don't have extra resources. And so I'm here to challenge you to kind of shift that perspective, and that One Health isn't something that requires more work. It is something that can save time and resources. And this is where that proof of concept comes in. Find evidence that doing One Health, collaborating, is going to save time and lead to a more favorable outcome. It's kind of like working smarter, not harder. So I can't pretend to know everything about Palau. So I am going to challenge you to answer these questions for yourself, because only you can really decide how you're going to do One Health in Palau moving forward. But here's just some kind of questions to get you thinking. So what complex issues do you face that would benefit from collaborating with multiple disciplines? What are some ways you can leverage community involvement to really enhance One Health efforts? What collaborations already exist, or where are they needed? And what barriers to information sharing already exist between your different sectors? And who are your most vulnerable populations affected by certain One Health issues? And what steps can be taken to protect the groups most affected? And lastly, if you've missed everything I've said, here are the key takeaways. I want to emphasize that there really is no one way to do One Health. It's going to be, and it should be, different for every nation. But you can start by mainstreaming One Health into existing efforts. It doesn't need to be this grand, we are now going to do One Health. You can start incorporating small changes, because over time they can make a big difference. And then again, community involvement is key, especially with limited resources. So I have included just a few resources. If you have access to these slides later, these are links to a couple of resources that I found really helpful when I first started kind of looking into how to do One Health, especially that last one, the One Health Commission. And then I don't know if there's time for questions, but I did, want to scroll up and just make sure you all have my email address. Anyone is welcome to email me anytime if you have questions, or if you want to schedule a meeting and talk face to face and brainstorm, or if you just want to send me cute pictures of all the animals in your Koror State Shelter, that's okay too. But that's all I have for you. So thank you guys so much. I really appreciate it.
Thank you, Kim, for your presentation. Okay. Our next talk is on healthy aging, and this will be presented to us by April C1 Lee. She's Technical Officer, WHO, Western Pacific Regional Office. Ms. Lee. Thank you.
All right, good morning, everyone. My name is April. I'll wait for my slides. I'm a technical officer at the WHO, Western Pacific Regional Office. Thank you so much for making time to be here. I know, it's not easy to get up early in the morning and get here. I'm not a morning person myself, so I struggle a little. Okay, my slides are up. Okay, so. Today I'm here to talk about healthy aging. And since all of us here were aging, and I really hope this is not news to you because, we are aging. And it's okay. It's a very natural process in our lives. And I want you to think about this question. What does healthy aging mean to you as an individual? No need to look around the room to look for older people. We're talking about ourselves here today. Okay. So please keep this question in mind this morning. Okay. So WHO defines healthy aging as the process of developing and maintaining the functional ability that enables well-being in older age. Now, what does that mean? So there are three components to healthy aging. So first is functional ability, second, intrinsic capacity, and third, environment. So if you don't remember anything from my presentation today, please remember these two slides. So number one, healthy aging is the process of developing and maintaining the functional ability that enables well-being in older age. And there are three components to healthy aging, and they are functional ability, intrinsic capacity, and environments. So now, what is functional ability? So functional ability is about having the capabilities that enable all people to be and do what they have reason to value. So functional ability consists of intrinsic capacity of the individual, relevant environmental characteristics, and the interaction between them. So my tip for memorizing this is functional ability equals intrinsic capacity plus environment. Okay. And in functional ability, there are different abilities, and this includes the ability to meet basic needs to ensure an adequate standard of living, including how we afford an adequate diet, clothing, suitable housing and healthcare, and long-term care services, including medication, and how the ability to learn, grow, and make decisions, so we can have our autonomy, dignity, integrity, freedom, and independence. So our ability to be mobile. So think about how you got here today this morning. So we have this ability to be mobile, to do daily tasks, and participate in activities, and the ability to build and maintain relationships. So the ability to maintain this relationship, the bond with our family members, our friends, those sitting next to you, and also the ability to when you do something nice for your friend, assist your friend or family member, when you mentor a younger person or care for family members, volunteering. So these are all our ability to contribute to society. Now, Next, what is intrinsic capacity then? So intrinsic capacity is quite simple. It is our mental and our physical capacity that includes our ability to walk, to think, to see, and to hear, and also to remember. So different levels of intrinsic capacity are affected by several factors, such as presence of diseases, injuries, and age-related changes. So the third component is our environment, where we live our lives. And the environment that we live in really shape the way that we can be and do. And environments here include our homes, community, and the broader society, and all the factors within them. So for healthy aging, what we want to do is basically reduce that green triangle, so over there on the right-hand corner, as much as possible. And we can do this by transforming our own perception of aging. So ageism, we have our internal ageism as well. So we want to transform that. We don't want that. And transform the environments to be age-friendly, and set up long-term care systems and services and prevent NCDs by detecting them early and also by detecting them early. And if we do have a chronic condition, we want to be able to manage this condition and to slow down the decline as much as possible. So again, we want to reduce the incidence of non-communicable diseases, such as cardiovascular and chronic lung disease, diabetes, and some forms of cancer that are associated with rapid declines in capacities in older people. Okay, so let's take dementia as an example. So there are 12 modifiable risk factors that account for about 40% of dementia globally. So we should note here that on the top, the green, in early life, less education, a social determinant of health, contributes to 7% of the modifiable risk for dementia. And you can see in the bottom, the later life, the purple section. So in later life, 18% of modifiable risk of, there's 18% of modifiable risk for dementia in later life. So what does this mean? So it doesn't matter how old you are, and you can start, we all can start to reduce our risk factors for dementia today. So age is no longer an excuse, and we don't want to hear, I'm too old for this and that anymore after this. So the life course of perspective allows us to better understand how social inequities in health are perpetuated and transmitted, and how they can be mitigated or even alleviated through the generations. Now, when older people, 65 years and above, make up 7% or more of the population, we say that it's an aging society. And Palau is an aging society. So in 2014, Palau reached the 7%. In 2021, it was about 9.5% approximately, and it will become an age society in 2033. So in 2033, we're expecting 14% of the population to be 65 years and above. So population aging will have a significant implications for our society. And we already see an increase in NCDs and chronic conditions in Palau. Older adults will have a more diverse health conditions and social needs that needs to be met. And these changes may place a greater burden on our health and social systems. But the good news is, with early investment in healthy aging, we can turn challenges into opportunities. So basically, we don't want to remain in the status quo on the left. We want to go to the right side, where we have healthier older adults achieving active participants and contributors to our society. And you may ask, so how long does this take? I'm going to give an example of Japan, which is a super age society in the Western Pacific region. And it took Japan about 60 years to transform health and social systems. Oh, and I see some of our Japanese colleagues here laughing. So it wasn't an easy change, right? Okay. And then Palau is going to be aging more rapidly than Japan. So what I mean by here, so for Japan, it took going from aging society to age society, 25 years. But Palau is only going to take 19 years. So we need to start preparing for healthy aging today. And our society, you see, is a cycle here. Oops, sorry, this is moving. We need to create health-enabling environment, but also the health system need to work closely with the society. So it's a cycle. So the health sector is no longer simply providing just healthcare services to treat diseases. It needs to work closely with social sector to enhance social determinants of health, including our living environment. So population aging is not a challenge. It can be an opportunity for significant opportunities for individuals and society. With early action in investment in older people, we can make this challenge into an opportunity so that they can be important contributing members of our society. Okay. And there needs to be a whole of society transformation in order to create an enabling environment for older people to remain these healthy, active, contributing members. So we need sustained multi-sectoral collaboration. Again, I mentioned how the health sector is not just responsible for this, it's all of us and all of our society and different sectors. So we want to be able to create not just a care environment in a hospital setting. That's not what we're aiming for here. We want to create an optimized environments in which we live our lives in, including care environment. So functional abilities, as I mentioned earlier, of older adults considerably varies. So you and I, we're different individuals. We have different needs and we need different supports. So it's the same for older adults. It doesn't mean once they age, they are one uniform community or group. So we all have different needs and we all need different support and services. And we need to be able to provide this customized, tailored services and systems to meet their unique needs. So WHO recommends community-based integrated care that involves the integration of health, social, and long-term care. And for this services to be provided to older people in a coordinated way in their communities. So as an older person, if these services are provided in the community, he or she doesn't have to travel all around to get hours to get these services. So we don't want that. Gas is very expensive these days, and it's not good for the environment too. So piloting community-based integrated care can be an entry point to promote healthy aging in communities and building on the existing community assets that we already have in our communities. So I'm not talking about bringing in care robots to Palau. No, we want to utilize the already existing communities, the assets, which are all of you here, to start this community-based integrated care. Okay. And for Palau, I am really, really hopeful because there are many, many assets for healthy aging already. And I'm especially hopeful because you are planning to do data collection. Where's Edom? Oh, yes, she's there. So she is going to lead the data collection effort with the hybrid and community survey that includes older people, and you'll be able to make evidence-informed policies and programs with this data. So data is very, very important. And there's a strong sense of community. So here, there's still social connection And it's very, very, very strong here. So unlike me, whom I unfortunately don't know who my neighbors are, but you all know who your neighbors are here, right? Okay, I see nodding there. Okay, so good. Yes, so there's still a strong sense of community, social connections here. So let's not lose that. Let's keep that. And I will make a more effort to get to know my neighbors when I go back to Manila. And there's soon we're going to have community health workers. So you will be going back to your communities to serve your communities, and you are a huge asset to healthy aging. And all these key building blocks to transform, all the assets that I've mentioned are key building blocks to creating an age-friendly environment, age-friendly society. And I believe the Ministry of Health and Human Services, the Public Health Office, led by Director Sherry, is leading the work in drafting a national policy on care for the aging in Palau. Sorry. So on my last trip to Palau, I've met with the Aging Council and also the Coordinating Committee on Care for the Aging. And I'm incredibly impressed with the work, the progress that they've made so far. So I was here in Palau last October, yes, around then, and they've already made so much progress. So the Division of Human Services, led by Chief Hera and her team, they've already conducted several focus groups and interviews with key stakeholders to really get their inputs for this policy, to really learn what is their need, what is the customized support that we need to have for Palauans. So for this policy, and we're also reaching, they have also reached out to youth, not just older people, but youth and all different sectors to get input for this policy. And there was the first national symposium on healthy aging, where they presented some of the findings from this focus group and then collected even more inputs from the participants for the policy. Okay, so I'm again very excited to see that Palau will soon have a national policy on care for the aging. And with all the vision, I believe, sorry, I didn't have time to add the vision to my slide, is all individuals in Palau lead healthy and happy lives with dignity and respect in age-friendly environments. So I think Director Sherry and Chief Hera and her team is going to be very busy because they are in the process of putting this draft together. I think there is an initial draft now, and I really, really hope that Palau will share your experience of drafting this policy with other Pacific Island countries, because there are not that many Pacific Island countries with a specific policy for older people or for population aging. Okay, so now before we end, so remember I said if you don't remember anything from my presentation, it's okay, but just please remember 2 slides. And the first is, so what is healthy aging? It's made up of 3 components. First, functional ability, intrinsic capacity, and environments. And then healthy aging basically is about developing and maintaining our functional ability as much and as long as possible. So just remember these 2. If you remember more, that's okay, and much appreciated from my end. Okay, so before we really end, because I have some time, I'd like to try out this exercise. And it's incredibly simple. I believe all of you made it here this morning, and all of you can do this, but I am looking for, wait, hold on, 1, 2, 3, 4, 5, 6, 7, 7 volunteers. So it's a very, very, very simple screening exercise. It's called the chair rise test. Maybe some of you have heard this before. So I'm going to demonstrate here. And then if you feel courageous enough to come up here, I do have a little gift. It's a limited edition merchandise. So, oh, I see hands there. Yes, thank you, too. Oh, even before, oh, 3, oh, wait, 4, did I see? Evelyn, I think I saw your hand, no? Oh, okay, not you. Okay, I have 3 volunteers. Any more? There are 4. Yes, thank you. Anybody else? I have 4. Oh, yes, thank you. All right, come on up. It's a limited edition merchandise that I brought all the way from Manila, which is only 3 hours away, but yes. Okay, perfect. So I'm going to demonstrate, and then I'm going to put the timer on. So is it okay? But I'm going to put the timer on. Okay, so I'm gonna put the timer on. In 14 seconds, just five of them. Don't do more than 5. Oh, if you wanna do more than 5, of course you are welcome to. It's your morning exercise. But just 5 is enough for those of you who don't wanna do more than 5. Okay, are you ready? All right. Okay, 3, 2, 1, go. Wow. Okay. Whoa. Oh my gosh. Okay, this I did not anticipate. Sorry. Are you okay? Are you okay? Are you okay? Okay, everyone okay? Okay, good. All right. Okay, something for me to make note of when I do this next time elsewhere. Okay. All right, well, that brings me to the end of my presentation, and thank you so much. All right. Oh, please get your bag.
Thank you once again, Ms. Lee, for your presentation and that exercise. Folks, we do have a couple of minutes before our next presentation. Should we do a couple of raffle tickets? Okay. Yes, go ahead. Timbre ate.
Okay, so the first prize is a clear backpack included with the $20. Lucky number is 669379. 669379. Do we have a lucky winner? No? Okay. Oh, yes. Okay. The next prize is also a backpack that comes with the $20. 669424. 669424. Yay! Mutawan. Okay, the next prize is also a backpack that comes with the $20. The lucky number is 669428. 669428. Yes, we have a winner. All right, that's it for. One more. Oh, one more. Okay. This is one mini JBL speaker. 669357. 669357. Yay! Okay, that's it for this morning.
congratulations to the raffle winners. Okay, to give us a talk on disaster preparedness and response for environmental health hazards and threats is Dr. Jesse Blees, Director, PPD Department, National Environmental Health Association, or NEHA. Dr. Blees.
All right, good afternoon. Good morning. Whatever time it is, if you didn't think that I was 90% Palau, and you will by the end of this next segment, I walked in about 15 minutes before my presentation and I see sweat dripping off of those that are waiting to load it onto the computer. And when I went on the cancer walk, my student Mong says, "You're more Palauan than I am," because I just walked out in the road to Crow Crossed. And I said, "No, it's just because I'm so big, I'm going to damage their car if they hit me." But I'm absolutely thrilled to be here because this is always a place for me coming home. And I do not believe in reincarnation, but if I did, I would have been a Palauan in a previous life, because I've been on island time my entire life. And for me, being here, I'm relaxed. I'm just enjoying the company, seeing good friends and people that have treated me like family. So just thank you all for everything you're doing here. And on behalf of the National Environmental Health Association, I am just proud to look out and see the work that you all are doing in public health and making a difference each and every day in everything you do. Next slide, please. So when I was here teaching 4th grade in 1996, you know, Palau has the bluest blues and the greenest greens of any place on the planet. And since that time, I have traveled the planet. And I have to agree, I'm sorry to those from Fiji or other areas, but I have to agree that there's the bluest blues and the greenest greens on the planet. And for me to be able to see this was last Sunday, going out through the Rock Islands as I went to go dive at Oolong Channel. And it was just, again, another part of the completeness of being back here with you all again. Next slide, please. A little bit about the National Environmental Health Association, or NEHA, as we call it. Our mission is to build, sustain, and empower an effective environmental health workforce, and our vision is healthy environments and protected communities that are empowered to be able to watch over and care for themselves, to live in wellness, and to experience life to its fullest, without the threat of the hazards and challenges that come with an unhealthy environment surrounding our children, our elders, and everyone in between. Drawing on the original effort when we were founded over 80 years ago, we've continued to grow and expand. And over the past 8 years, since our executive director, Dr. David Dijak, took the helm, we have continued to grow in an amazing rate, going from about 3,000 members to now close to 7,000 across local environmental health jurisdictions, as well as in private business affiliates and the uniformed services. We enjoy and are passionate about the work we do. My staff is passionate, and they're empowered, and they love the work they do. And it's a pleasure to go every day to engage. You know, I don't go to work now because everything went fully remote after I moved to Washington, D.C. as a result of the pandemic. But even though I don't go in and see everyone every day that way, I sit in front of them and I watch and I see the work that's coming out. And I can tell you that the passion that I have, that I'm here with, my entire team has. And they inspire me every day to be a better leader. And I watch that unfolding here from Minister to Director Scher to Calvin and the others that I've gotten to know better, watching each of you work together, the staff with leadership, with a passion and a zeal to make health better. Next slide, please. It was September 26, 1996, about 5:45 p.m. I was in central Karor and heard a big boom, and all the power went out immediately. And we were wondering what just happened. We talk a lot about disasters, about different types of disasters, what causes them, what can lead up to them. And many times we have a lot of warning. But that didn't have any warning for us that we understood. We meaning everyone here in the room that remembers that day and what happened. And immediately all power and water was cut off. When you don't have utilities, how difficult is it to maintain the environmental health of your population? Do you guys wake up with cold sweats on that, Calvin, when you think about what could happen? Because when you don't have the ability to sanitize and ensure that people have access to water, they don't have power to be able to run pumps, to be able to run air conditioning or fans, to be able to take care of basic cooking necessities, everything all of a sudden comes to a screeching halt. And it doesn't matter how developed a community or a country is, when a disaster strikes, it can reduce you immediately to what it would be like if you had no infrastructure at all, because it can suddenly be gone. And so we need people to be able to stand in the gap. Next slide, please. For those that were not here, this is what we saw when we got over there to the bridge. And it was just a complete change in everything in the way of life. And so as I look back on that, I didn't know what environmental health was at that time, but I understood the impacts. And that thing became clearer and clearer to me as I continued to study and work and spend more time working in other countries and learning to understand what the needs are and the threats that impact our communities and our health. Next slide, please. So what I'm going to be talking about today, I'm going to go over looking at and reading the signs and keeping an eye on the horizon. I'm going to talk about the new normal of disasters and concurrent disasters or cascading events, environmental health emergency preparedness capabilities. Those of you that are in public health recognize the public health emergency preparedness capabilities or FEP capabilities, but my team and I worked on developing the environmental health capabilities last year. Equity and environmental justice, looking at change and the process of change, engaging in community resilience, and providing some recommendations. Next slide, please. So those of you who are not as familiar with environmental health, a definition that is out there is the branch of public health concerned with monitoring and mitigating those factors in the environment that affect human health and disease. Or, in other words, the food we eat, the water we drink, the air we breathe, the homes we live in, the toilets we flush. I could keep going on and on and on. Each one of those aspects. And by the time you go through the exhaustive list, it's really easier to just say it's everything, everywhere, all the time. That's your environment. And that impacts your health. Where you live, where you work, where you play, where your kids go to school, all of that impacts their health, your health, and the health of our communities and our populations. Next slide, please. So we need to start getting good at reading the signs. People that hunt are following the signs for the game that they're following to keep an eye on that. I was taught a different kind of sign or a way to scan the horizon when I was young. I grew up on the Oregon coast, so I've always been near the water, and it flows through my veins. So if I'm too far from it for very long, I just don't function well. But when I remember from the youngest age when I'm toddling around, my parents always saying, when you're down at the beach or you're near the shore, always what? Always keep an eye on the ocean. Never turn your back on the ocean. The waves on the Oregon coast, big percentage of the time, are angry and stormy, and they'll sneak up and they'll hit you. And when you're a young boy or a young child, that can be devastating. Even when you're an adult, that can be devastating and sweep you out. So if we have to keep our eye on the horizon, keeping our ear to the ground, listening for, watching what is coming next. And as we look at what's happening around us, we look at harmful algal blooms, we look at other challenges with water. The next big thing that's going to be coming that will impact all of us is the scarcity of water. And you all know that. You had a massive drought in 2015 or 16, correct? Somewhere right in there, that you didn't have access to drinking water, safe water for the communities. That's a huge problem. Beyond that, there's drought, there's also floods. And when floods hit, now you're dealing with a whole different set of events where it can contaminate homes, you can lead to getting mold, it can lead to exposure to other pathogens that are in the floodwaters. Big challenges. We're coming into a new era of environmental public health, and it's an era where, because of the way we've not taken care of our environment, that the environment is turning on us. And we need to keep an eye on that, and we need to develop some plans. We can't sit by and just wait and continue doing things the way we're doing them now. If we do, it will hit us. An ostrich can bury its head in the sand, and the lion will still get it when it's there. We have to be ready and keep our eyes open for it. Next slide, please. So as we're thinking about this as a new normal, and we know that there's crises coming. When I was here in 2007, we were doing training on pandemic influenza preparedness. And in, 2009, we had H1N1 pandemic that went around the globe. And now we've had another massive pandemic that has impacted us for the past 3 years. It won't be the last one. But we're looking, we know that. We knew that was coming. When we were doing those trainings, my team and I were there working together with Pearl Muramoto, and we were saying, it's not if, it's when. And here we are. And it's happened before, but we forget what happens. We forget the threats that come. We forget the challenges with communicating to people and wanting them to wear masks or isolate at home. You're taking away their freedoms. The people are going to rebel against that. We've forgotten a lot. And if we could keep our minds focused on learning from history as well as an eye on the horizon, we would do much better by ourselves and for those that we're trying to protect and care for. Next slide, please. Wildfires in December. So not just this past December, but a year ago, December, in Boulder, Colorado, there was a massive wildfire. It took out 1,000 homes. It impacted the community drastically. Hospitals had to be evacuated. Skilled nursing facilities had to be evacuated. In December, my associate director used to work at Boulder County, and she reached out and was communicating with the environmental health department there. They were running everything from being the incident command to logistics to reaching out and guiding through the entire response. And after things settled down and the evacuations were done, that they helped to coordinate the evacuations of the hospitals, then good intending partners in the community said, oh, we want to help people to be able to get access to their valuables that, maybe survived the fire. So they're giving them these sieves or screens to go out there and screen through the ashes to find important valuables, which seems like a nice gesture. But if you're thinking about environmental health, do you know what is in those ashes? Do you know the types of things that were burning? When it burns so hot, cars melt. The heavy metals, the toxins, the things that are in those ashes, people weren't wearing protective equipment. They shouldn't have been anywhere near that. And so the public health agency turns that over and say, hey, we got another call for you, environmental health. we got to work on this. How are we going to counter this? What are we going to do? And how do we help people to understand that the risk is not worth it? We have to help to protect and inform and educate each and every day. Next slide, please. So what's on your horizon? Aidil, are you here? What vector is this? Yeah. What all does Aedes aegypti transmit? Dengue, chikungunya. You remember any others? It's a bad bug, and it's everywhere, and it likes people. It likes to live in your home. It likes to lay its eggs in little tiny drops of water found in some tires or in a little cup or a little thing around your front door, any place where it can be able to lay that and then hang out in your home and bite you when you're least suspecting it. And it does really good at it. And so when we have more and more populous areas and individuals that are more at risk, and I'm going to get into more of the conversation of at risk in a moment, but it's very easy for the outbreaks to occur. What about the storms? So this storm, the picture up in Triangle from Typhoon Haiyan, I was over in the Philippines responding to this disaster. I took a team over there and was leading a response on the island of Panay. And I didn't realize at that time what had happened here after it passed through. But it decimated up there, and that's just one moment. And that one you had more awareness of, right? There's a storm coming, it's already hit in one region and it's passing on through. But they don't always give that big of warning. We don't always know. We can't read all the signs. But we do know, we can see when things like El Nino events are coming, when there's likelihood of a drought, we can read those signs. And so we need to get good at what are we going to do? How are we going to navigate this storm? What agreements do we need to have in place with other regions that could be able to provide support to our communities when we need it most? Next slide, please. So I mentioned the environmental health capabilities, and this is a list of the environmental health capabilities. We had a work group comprised of about 15 different individuals ranging from federal, state, and local environmental health experts, academia, and together we went through what are the key capabilities the environmental health needs to be able to perform in the event of a disaster. And I'm not going to read all these for you because there's a couple of slides here of them, but just scan through and take a look at these. The activities and the role that the EH workforce plays is big, and it outpaces the capacity of the workforce to do that across a region. We've talked about 16 states and the challenges with, how many staff do you have, Chief? 13. How do you cover the needs across 16 states with all of these capabilities that I'm going through? It takes a community, it takes a village. You cannot do that just with the workforce. You need to be trained on how to do that. You need to know exactly how to perform each one of those. You need to be able to tell others and give the right messaging and have that messaging ready to share that in advance so that you can give everyone the best opportunity. But it's going to take more people coming together and working together, which is going to bring me into the next part of the conversation, which is on equity. So next slide, please. Next, and one more. So you've seen several different depictions of equity this week, and this is another one. I'm going to take it one step further than the others have. So when we're responding equitably to disasters, it disproportionately impacts geographic regions and the populations. When I was in Haiti responding to the earthquake, I went up on a ridge just outside of Port-au-Prince. I ended up there by mistake. There was a road closed off because they were moving debris, and my wife and I were part of the response team, and we ended up on this road, and along there, almost every single house was completely destroyed, and they had zero services. So this was about 2.5 weeks after the earthquake struck. No delivery, no water, people were up there, and I immediately feared for my life and for my wife's life. Like, I just came up here driving an NGO vehicle, and I have nothing to offer. What am I going to do? But it was odd because you look there and you'll see destroyed, 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 and then one that's perfectly standing, and then everything else is wiped out. And over again, you go to different regions where an earthquake is struck or something like that, and you go, why is that one standing still? And it makes no sense. It's made exactly the same as the rest. It disproportionately impacts. Some of that is random, but a lot of it isn't. A lot of it is tied to disparities that are related to inequities that continue to be perpetuated within our communities, whether along lines of resources and income, whether along lines of racial or ethnic background, cultural language barriers, disabilities, immobility. There are so many different aspects of our population that make the impacts unequal the way they strike. And our response has to be metered and changed as well. Next slide, please. So inequality, we have the tree there, and what do you notice about the tree? It's leaning. What else do you notice? There are more fruits on one side of it, right? Next slide, please. So that's unequal access to resources. So let's equal it out, right? So we're going to give everybody a tool for assistance. Did that help the individual that couldn't reach the fruit? So this is similar to the boxes, right, that didn't really help them to be able to see over the fence. Next slide, please. So that's equality. Then we talk about an equity approach. So now we've got, what, 2 different sizes of ladders. So now we're customizing the response and the tools that are needed and identifying the challenges to address the inequality. And that's where a lot of us stop with this analogy and saying, okay, so the lesson here is we need to look at it as equity. Next slide, please. When we talk about justice, actually, can you go back to the previous one just for a moment? What do we still see here? Even though they can reach, there's still not as many fruit available. Next slide. So in the next slide, fixing the system and using a systems approach to offer equal access to both response, tools, and opportunities, straightening out the tree, ensuring that the tree has its water, has its fertilizer, what it needs. Now it's growing fruit and everyone has access to what they should have. We have to take it. We have to think about justice. And when it comes to environmental health, we have to think about environmental justice. If it's lead poisoning prevention and I'm in an urban population, the urban poor, and in the US, urban poor Black and brown communities are disproportionately at risk for getting exposed to lead. The children are more likely to have exposure to in older homes with paint, with other exposures. That's an inequity. And so when we have resources, if we just put it out there to all the communities where everybody who has lead-based paint, we're not going to stop that inequity from happening. So how do we get into the region of justice? And so I encourage each one of you in your daily work, be thinking about the work you're doing and be thinking about the disparities that exist within your target populations and who is missing that and what can we do to make sure that we are just and equitable in the work that we're doing. Next slide, please. So now we're talking about change. And change, some people are fearful of change. It's got an unknown. It disrupts the normal. Other people embrace change. Change isn't something to be afraid of, but we need to think about what are the components of change so that we can navigate through it successfully. So if you're looking at impacts, there's opportunities and there's hazards. There's risk and there's growth in change. If you're looking at how you're going to plan for change rather than just being impacted by it, now you can look at it and say, well, what are the needs or gaps? And when you've identified those, now you can develop your programs to be responsive to those needs and gaps so that your implementation can have the biggest impact where it's needed most so that you can have your equity and justice. And identifying the barriers and the facilitators. There's always barriers. Just like in every group, there's someone who's got the Eeyore syndrome, right? Glass half full. And then you have someone who's really positive and just like, we can do it. Si se puede. Yes, we can. We can get it done. So how do we adopt some of that? How do we bring that in and say, okay, well, what are the facilitators? And in the case when we're talking about communities and the impacts that is happening there, we can work within the communities. Who are the trusted leaders that we can connect with? What are the facilitators to help us get the work done we need to achieve? Next slide, please. What I didn't say on that slide also is the biases or attitudes and beliefs. Those impact behaviors, and so we need to think about what those are and how we can help to reframe. Sometimes that maybe means giving a new identity to a gender group, identity to an age group, identity to a disability group. How do we look at a strengths-based approach? What does the community have? What do individuals have that helps them to be able to overcome these challenges? So concentric circles, I like the water analogies again. You know, I'm in Palau, what else am I going to talk about? So you take a drop and you drop something in the water, a drop of water, and it makes a little ripple. And those ripples are circles. They keep growing out and going. Next slide. Those can be good or bad. You've heard an earthquake? Those have ripples too. And the waves from those continue going out, and they can get bigger and stronger as they oscillate and tear down and destroy the buildings, right? So you can have recurring risks, and you could have recurring coordinated and timely response activities. And each time you're doing that, you're making ripples and waves. Are you going to make ones that are helping to make a positive change and difference in your community? Or are you going to allow or stand by while you see the same drip happening in the same place, which is making those waves get bigger and bigger, and it's impacting parts of the community worse than the others? Next slide. I couldn't talk about this topic. I can't talk about public health anymore if I don't talk about climate change, because it is the single biggest existential crisis facing life on Earth. Every community, every public health challenge, every environmental health risk and threat are all impacted by changes in our climate. Whether you're getting more rain, so now you have more places for mosquitoes to breed, you're going to have increases in the population, you know you're going to have more chances for an outbreak, or whether it's a drought in another area, or whether it's cold or warm. Each one of these things exacerbates challenges. When I presented on climate change up in New York last year, I was sharing about communities there where the difference between those with tree cover in an urban setting and those who don't have the tree cover, again, thinking about the disparities, those that don't have the tree cover, don't have the green spaces, are generally the minority communities. The difference in temperature is between 84 degrees in those with great tree cover and 117 degrees in those that didn't. Nearly 30-some degrees of difference. That is huge, because in those same communities that don't have the tree cover, they're also less likely to have air conditioning, also less likely to have the resources to be able to cool their homes effectively if they do have access to air conditioning. So when we're looking at this and we're thinking about climate change, what are the impacts that we see? What are the events that has to impact here in Palau? Sea level rise, frequency and intensity of storms, redistribution of vector populations and where they will be found, the types of vectors that may be able to live if temperature becomes continuing to change as well. There's so many areas that can impact. Next slide, please. So again, climate change, it impacts the entire globe, but it's not equally distributed, just like our other hazards. Whether those are summer heat waves in Seattle, where a heat dome killed 23 or 24 people the year before last, or air pollution, and the impacts of air pollution as those are increased and trapped within an inversion area, or the flooding, which is providing challenges for all aspects of your home, as well as for resources, food security, the vector-borne diseases, the changes for things like Chagas disease. Malaria is changing where it can show up at, and we're getting worried about seeing it back in other areas in the Americas again, and lead exposures. There's so many components to that. Next slide. So as we think about environmental health and enhancing the resilience, what do we do? So I alluded to it earlier when I talked about finding strong partners within the community. Resilience is having the ability to absorb, not necessarily bounce back. I've heard it talking about bouncing back to normal. It often defines a new normal. But the ability to absorb an impact and continue on and finding a way to to achieve wellness or health again through that process. Each one of us has a resilience zone. It's not just the resilience of our climate or the resilience of the community. You individually have one. How many of you during the last couple of years realize that you're a lot more on edge than you may have been before, where someone comes up and says something where before you might have just shrugged it off, and now you blow up at them and pound them or scream at them or storm off, I'm not going to talk to you for a week or whatever else might happen. I found myself facing those challenges, even with my kids. I'm like, why did I snap at my son like that? And so we can do something about it. We're not just victims to stand by. There are tools and resources we can use to widen our personal resilience, and there's tools and resources we can use in our communities to help to help them become more resilient. Next slide, please. So the next couple of slides give some pictures to the words I'm talking about. When you have a strand like that and they're frayed, there's not a lot of strength. Next slide, please. But as you bring your community together and you weave the fabric together, you can build strength. And together, I remember my dad built a play fort for us when we were young, and he put this netting on it. And the netting that he put on it, it didn't seem that strong, but he was a fisherman in Alaska, and he talked to me about catching whales in the net. And if you know how much a large whale can weigh, those nets are strong because the way they're woven together, and they're each distributing that impact so that they're resilient to the force of something coming and hitting the net. So how do we make our communities like this? Do all of our communities look really nice like this? No. Next slide, please. There are challenges. There's areas that are frayed. There's places where there's holes. Those impacts that we were talking about, different cultures, different mobility capacity, different status of your own resilience zone. Do you feel like you can make a difference in your community? And if you just kind of feel like you're always getting run over, you don't have a lot of hope of what you can do or impact in a change. But if everyone else around that hole and that gap is there and they're woven together and we see and we have our eyes open and we're working to build strength within our communities, we can build that resilience together. So when the disaster strikes and the power goes out, do we have someone that already knows, hey, we have a map, we know where all the elders live, we know those that are mobility challenged. We've already somebody that's over there, they're checking on them, yep, they're okay. Or so-and-so doesn't have water, we need to get them some water. Okay, well, this person had more space, they had a double garage, they had some supplies that were there. We can make sure and store some of those there and make sure people can have access. We can work together and become more resilient as a community. We have to identify our strengths. And those strengths can be used every day. Don't wait for a disaster. If you wait for a disaster, that's like when we write our preparedness plans. They look really good on paper. I've heard things said like, oh, well, we're just going to have the skilled nursing facilities discharge those patients that don't really need that level of care. They're going to go home to their family members, and then we're going to use them for our surge capacity. That's logical. That sounds like a good idea. Do those agreements exist with each one of those skilled nursing facilities? Are they going to discharge their patients? Are there legal ramifications? Are you even allowed to do that? There is so much that I will not name any health agencies, but everybody's guilty of it. You write a plan, we have to write this plan or we can't get our FEP funding, we can't get our funding, we're not going to be able to be reimbursed when a disaster strikes, let's get a plan, check that box, I've got it. But if you make assumptions within there, and those assumptions aren't based in reality and they're not operationalized, they can't be operationalized, you're not going to be ready for anything. And even if you can find the dusty binder on the shelf, if you open it, the guidance in there isn't real unless you've practiced it, trained it, used it, and made sure that the things you say can happen are going to happen. Next slide, please. So our communities really need to look more like this. Different threads, different styles, but woven together and building a fabric that will make sure that can carry us through when disaster strikes. And the anchoring workforce that has to address these environmental hazards that are there, the food insecurity challenges, the contaminated foods, the contaminated water, storage tanks that are not maintained well, that are just growing your next population of Aedes aegypti, whatever the things are, if we're not working together in a community, if we don't have people checking the tanks regularly, we can do that. It does not have to be Calvin and his team. We can work within the communities. There's men's and women's groups. There's community-based organizations. Dr. Dever, he's got community health workers. We could train community health workers. We can give them an environmental health training course. It gives them more capacity, gives them something that they can now say, here's a new resource, new tools that I know how to use, and they can be in there as trusted agents within the community to make a difference. And I've used that model. I did that in the eastern Coachella Valley, halfway between Los Angeles and Palm Springs, with migrant farm working communities that were Spanish-speaking. We developed the resources in Spanish, we taught them, and for each one we taught, they taught on average 25 other individuals. Talk about return on investment. It works. Next slide, please. So equity is really the cornerstone, and it needs to be front and center in how we think about science and moving forward. That was spoken by Dr. Claudia Thompson from the National Institute for Environmental Health, Safety, Population Health Branch Chief. I would put in there justice has to be a part of that as well, but it's that community aspect that we need to bring together. Next slide, please. And so if EH is a partner and we are able to engage in addressing those threats and hazards in our communities, helping the communities to identify them, training them on how to address them, they're going to be much more ready when a disaster strikes. We used to go and tell everybody the number one thing you have to recognize when a disaster strikes is yo-yo. You know what that is? You're on your own. The government's not coming to the rescue. They may come in a week or 2 or 3, depending how big the impact was. If you're expecting somebody to come and provide you what you need to survive, you may not. And other people that have less capacity than you are a lot less likely to be able to do so. So let's not be on our own individually. Let's come together and be a community, and let the community be the strength that binds us all together. All right, my last several slides are about recommendations. Next slide. So we need to integrate environmental health into emergency preparedness, response, and recovery planning and exercising. Exercising has to be a part of that. You're practicing for the disasters. We have to be aware of the specific environmental health capabilities that must be able to be performed depending on the type of disaster, and we have to have staff that are trained to perform those capabilities. Next slide. We have to focus on collaborative planning and foster communication among the environmental health, the public health workforce, the private sectors, other personnel, community organizations, and community members themselves at all levels and all layers. Now, I started a project on community resilience for Los Angeles County, massive county. And we're working there and we're having these dialogues and conversations, and everybody's using the word community resilience and using the word community, and it's all over the place. And it wasn't right away. It probably took almost 3 or 4 months, I know, maybe I'm slow, to realize that when people said community, they weren't even talking about the same group. Because when you're at the state level, the community that they're talking about is at the local level. And when you're at the local level, the community that the local health agencies were talking about were the community-based and faith-based organizations. It wasn't the community members. And when you're in those organizations, your community is your congregation or the population you're serving, right, that has a certain characteristic. And then, down there, finally you get down to the neighborhood level, which is also community. So we have to have a common dictionary. One of the biggest challenges we have in all the work we're doing is having the right words and the right information to make the right decisions. The underpinnings of that are data, and we have to have data appropriately used. Don't lead with data when you're going to try to make a change. I can go and speak till I'm blue in the face to someone around, well, someone that I might know that has a bad habit that I know is really bad for their health, and I can talk all day long. It's not just data and information, because there has to be a connection. There has to be a relationship. You have to have a way to have it matter. Why does it matter? Why does what I have to say matter to anyone else? If I don't know your values, I'm not going to be able to impact you and help you to make a decision to change your community. So if I don't do my homework, if I don't spend time with you, if I don't go, eat sashimi with you and go out on the boat and go spearfishing with you, I'm not going to know you, and I'm not going to have a voice in your community. And if I don't have a voice in your community, no matter what I say, I'm not going to make a difference. We have to build those relationships, and that's costly. That is really difficult. The health agencies, everybody's working on a dime. It's feast or famine. Right now, there might be a bit of a feast because there's some COVID money still flowing through the system. When that ends, it's back to saran wrap. We're all stretched like saran wrap. How much can saran wrap hold? It's not a net. It's not like the fabric we were showing there. It's pretty easy to rip that stuff. So we really need to think about that and work together to make sure that we understand. But as we're going through and understanding the community, that means we have to look for indicators. So we've had some great conversations on indicators from our ASTO team that was here working through talking about how do we look at what we need to measure. How do we determine how we're going to make a difference and if we're making a difference? We need to know those. And if you know what the indicators are, you know the data you're going to collect, now you have to build the data system to house all of that. But if you build a nice house and you never go live in it, what's the use of having a house? If you build a great database and you have all the data in there and you don't do anything with it, why do you need the data? I know a lot of epidemiologists, I'm sorry, Mong, I know a lot of epidemiologists that love data so much that when an opportunity comes to ask a survey, they ask so many things that an hour later the people's eyes are crossed and they don't even know what they're answering, right? Because they're answering stuff that it's just like, oh, I could ask this, I could ask this. How much of that is needed for the program you're trying to do? Because there's such thing as survey fatigue. We don't need all that data, so we need to decide what is the data we do need. What are the essential components we have to know, and just get that. Be kind to those we're trying to ask information from. They've got their jobs and their lives and their family, their struggles. They've already got all of that. We're asking from them, yes, because we want to provide support for them, but we have to recognize that that comes at a cost, and that comes at relationship as well. So sometimes you get people to participate by giving them money for every survey they do, but even then, don't ask so many questions if you're not going to use it. Next slide. So collaborate with national and state government bodies to clarify the role of EH personnel or those that are serving to meet the hazards head-on that are related to the environment. If they need to be part of and working in the staffing for the emergency operations centers, serving as members of specialized EH strike teams. If you're not aware of environmental health strike teams, we are working right now developing a national standard to provide guidance on how to form and use them. But those are pre-set teams with each member having specialized training to do a specific aspect of the environmental health response. So you have a group an individual who knows the food safety, and in their go bag they're going to have thermometers and their food safety things. You're going to have someone that's going to be doing water, and they're going to have the test kit to make sure to know if there's enough chlorine or if there's any E. coli in the water. So they're trained and they're equipped, and then they're deployed in response to specific threats and hazards in an emergency. That's a fantastic model, and it's a model that can be used at a lot of different levels, in the level of a community, or in the level within the state government partners, or in the level of the MHHS. I'm putting together the teams that need to be part of the response, and then participating in task forces and building those connections and relationships and having working groups so that you're hearing the communities. Because if you come in there saying, we know what your problem is, you're not going to get to the outcome you're trying to get to. When we were working with the communities out in the eastern Coachella Valley, we knew what they needed for preparedness-related stuff, but they were more worried about the fact that their kids had to walk, putting bags on their shoes to walk through 1.5 feet of mud from this trailer camp to get to the bus stop. That's what they were worried about. The disaster for them was, how do I get my kids safely to and from school? And if we ignored that and we didn't hear that and we didn't put that into part of our planning and what we're going to do, we aren't going to have the relationship and we're not going to make progress on it. And I'd like to end with the last slide, and I'm going to change the direction of this. I talked earlier about our individual resilience. We've all gone through a lot. The people you go to work with have gone through a lot. Your colleagues have gone through a lot. Your patients have gone through a lot. Your community members. So when you go and you do an inspection, when you go and you deliver a service, and someone snaps or is crabby and responds back, Don't bite back at them. My request is to lead, work, and live with compassion, with mercy, and with kindness, so that wherever you go, go with all of your heart. Telling people, recognizing, acknowledging that they're strong, they're beautiful, they're brave, they're capable, you believe in them. Be that message of hope. There's so much trying to tear us apart. Our family's under attack, our communities are under attack, but we can make a difference. You don't have to be a social worker or in behavioral health services to recognize that we all have something that's inside of us that needs to connect to someone else. And if we can lead like that, I'm talking to the directors, the ministers, the chiefs, if we can lead like that, your staff will see a difference in you. And if we can go into our communities and live like that, the impact will be there much stronger. The relationships will be there. You'll find traction. You'll find fertile soil for the messages that you're sowing, and you'll be able to get good growth and have things that come out of that that will positively impact the health and the lives of your community. Thank you so much. Thank you so much for inviting me. Chief Calvin, thank you for jumping on the phone and being on there regularly as we start to plan out. And this isn't the end. This is the beginning. I'm going to bring a team back here. I'm going to bring 4 or 5 people. We're going to deliver training for the environmental health staff. We're going to be discussing with members of the staff at the state governments, and we're going to be talking about how to bring the messaging into the community. So we're going to come back and do providing of some trainings in those spaces, and I'm looking forward to it. And I know that each one of you that are here that are part of the MHHS entire staff and group, you're here and you're passionate. Sometimes you get tired, sometimes you get burned out, and we can lean on one another. Let's get through this and let's make an impact, and let's make a healthier Palau where everybody can be proud to be a Palauan man, to be proud to be a Palauan woman, to be proud to be a Palauan boy or girl or someone who can be proud. And I say, you know what, this weakness that I have where maybe I'm a little bit difficult on concentrating, but wow, you can really play music really well. How do we look for those strengths and build from a strength-based perspective and put that into everything we do? And with that, I'll stop talking because I know I've already gone over, but I hope that that is okay. And I wish everybody a wonderful afternoon and look forward to seeing many of you tomorrow as we go back out into my favorite place on the planet.
Thank you, Dr. Bliss, for your presentation. Thank you so much. Folks, just a quick reminder, we have please access online through email. All those who register online for your evaluations, we need you please complete and submit those. There are also hard copies at the register table for those who wish to fill those out, hard copies. Okay. Father Francis X. Hiesel is the parish priest for the Santa Barbara Church, and he will give us a talk on suicide, the theories of suicide, and the application to the local context. Father Hiesel.
A theory, not theories. An application is what I like to think of it as. A disaster, a cultural disaster that affected not just Palau, but the rest of Micronesia. One limited, I hope, something that we've already experienced and we're working our way out of. In this respect, I think it's fair to say that Palau is first and Palau is last. I'll explain what I mean in the course of this talk, the presentation. The presentation is on suicide, and it's not theories. As I say, it's my theory, my understanding of what happened. But it's an invitation for other people to join in the conversation. Because any presentation, I've lived here long enough to understand that any words that I have to say are not the end of the conversation. It's really just the beginning of the conversation. And I've had that experience many, many times here in Palau, both in church work and in presentations like this, community presentations. So I hope that you won't think that I'm trying to have the last word. I hope that you will take this as an invitation to think more about this and to continue, not just feedback to me, but the discussion with one another on what we might do to deal with this conflict and with situations like it. Could I have the first slide, please? There you are. There is suicide over the years. Now, suicide in Micronesia, throughout the islands, not just Micronesia, but throughout the rest of the Pacific, is an age-old or century-old phenomenon. It didn't start in the 1960s. We have evidence from Guam, we have evidence from Japanese times here that, that there was suicide. There was suicide at a rather low rate. We'll say more about that later too. But all of a sudden, there started a suicide explosion, and you can see it in this chart here. Sorry, I'm looking for a way to use this microphone to point over. So you see that this, I don't know if you can read this, but this starts with 65 to 69. And 70 to 74, you can see the enormous and quick increase in suicide. Well, actually, I'd rather have that slide on, if you don't mind. Okay. But you see the 5-year totals over there. They're going from 26, that's 5 suicides a year, up to about 250. You know, you could see that. So you're going from a couple suicides a year to 50 suicides a year over a period of maybe 10 years, 15 years, 20 years or so. And you're keeping at that level. Well, it drops a little bit, but it drops considerably in the late 90s. But it remains relatively high through the early 2000s, I mean, the first 2 decades of this millennium. Could we have the next slide, please? There's your graph of the yearly suicides. Now, when we talk about Micronesia, we're talking about FSM, Palau, and the Marshall Islands. This does not include the Northern Mariana Islands. But you have plotted against that Guam. So you have a much lower rate in Guam, low number of suicides in Guam, and that increases to the point where the Guam number is larger than the Micronesian number over the past 5 years or so. Next, please. Translated, now some might think that, oh, of course, the population was growing over those years. But this is the number of suicides over and against the population growth. So this gives you a better method for calculating what was the peak of suicide at that time. You can see that the suicide rate was only about, 2 or 3 or 4 in the early 60s. But increased greatly, and you can look at this in the terms of a rate where it has remained, kind of steady over about a 30-year period of time. Now, I said Palau was first. What I mean by that was that in the years 1960 to 1969, there were recorded 38 suicides throughout Micronesia. Of those 38, Palau accounted for half, almost half, 18. So Palau experienced the suicide increase before other places did, but other places caught up to it, as you'll see later on. Could I have the next slide, please? The suicide rate by islands over that period of time was, you can see Chuuk is high, but good old traditional Yap is even higher. How do you explain that? And then, of course, Palau. Palau would be just a little bit higher than the Marshalls, and you got Koshrai rate rather low there. Before we get to the age distribution, could I have the next slide, please? Yeah, okay, go back, please. Okay, I wanted to say something about suicide in the past. I did mention that we did have records of suicide in the past, and the records indicate that the rate per 100,000 was only about 4 to 6. That is throughout the 1980s and the early 1990s. Suicide was known. We have stories of people paddling off in canoes, particularly old people, to remove themselves from situations in which they perhaps thought that they were a burden. But we also have this enormous increase over a very short period of time. An increase that might be a function of social change. I mean, is this just random? I don't think so. Is this just people reacting to stress? I don't think so. Stress? All of a sudden, everybody reacts to stress in this way? No, I think that the ground is shaking. I think that there's something of what I referred to yesterday as an earthquake, a social earthquake hitting a place, and people reacting to this. And now let's have a look at some of the, next slide, please. The age distribution of the suicides here over that period of time, you can see that they're clustered in between the ages of 15, even younger than 15, let's say 10 years old, to 25 years old. So about 60-some% of the suicides occur in that period of time. This is very different from what you find in other parts of the world, like the US, where the suicide rate in the past has increased with over the years. I mean, what I mean by that is increased with age. So the people my age are more in danger of committing suicide than, let's say, people of your age. But this has changed here in Micronesia. That there is, as I say, there's a great number of people, in that younger age group who are taking their own lives and presumably taking their own lives impulsively. And the impulsivity is a problem. Next, please. When we talk about suicide, we should not attempt to think of this in terms of equity. There is not equity, gender-wise, in the suicides, as you can see there. The suicide rate, or the suicide problem, is something that affects males, has affected males far more, not just a little bit more, but as you can see from the numbers there, far more than females throughout the area. That's not just true of Palau, that's true of every place that we know. The biggest difference actually is in the Marshall Islands, where we only found 3 suicides over the course of 20 years. Next, please. The cultural patterns of suicide are there's certain reasons that people commit suicide, and these reasons are culturally distributed. So that in Japan, when they put up every year that list of people who pass the standard test, the suicide rate jumps. People are reacting to their failure, their disappointment, the knowledge that their family will be disappointed that they didn't pass the exam. That's not true in Micronesia. People go broke. People in the 1920s were jumping off buildings at the Great Depression. That's not true in Micronesia at all. So it doesn't have to do with just shaming or failure as such. It's more culturally conditioned than that. It's not due, as I say, to angst, failure in school or work or public shame, but interpersonal problems, especially those related to the family. And the most important is a rupture between the individual and the family. Now, beware of this. Beware of the fact that there's a certain kind of individualism that underwrites much of what we Americans say. And that is truer these days than it was even before in the years, let's say, after the war, the years when I was growing up. The assumption is that there has to be sort of an individual sense of self-esteem. And the self-esteem is based on being able to do something. I don't think so, not in the islands. I think that the self-esteem, or at least I've always thought that the self-esteem, is rooted in something that's collective. It's rooted in family. It's rooting in knowing who you are and where you came from, and the connections that are so important to you. And when that's threatened, watch out. That's when the danger starts. The other thing that you have to understand about suicide is that there's a cluster effect, a contagion effect. It's like COVID, only not as bad. It's like some of the contagious diseases that we deal with. We have stories of people attending suicides, funerals, and young people especially, who are so impressionable, and saying, wow, all these people gathered to say goodbye to a friend of mine, and then, as I mentioned, I think yesterday, doing the suicide themselves. So you've got clustering. This is an example in Chuk. You can't see this, the numbers so well in here, but what this shows, this is a distribution of all the suicides over that 5-year period of time. But it's a cluster by island. So these represent different islands from or island groups from the top down to the bottom. And it's just a way of showing that what happens in one place affects another place. The example I'm fond of using, and possibly I shouldn't, but in 1991 or 1992, the number of suicides in Guam increased from 12 a year to 24 a year. That was the year that the governor wrapped himself in the Guam flag and shot himself. There was an immediate effect on the community in Guam, and that effect has been continued, I suppose. Let's not blame it all on him, but let's just say that that initial jump was part of this effect that we see, this contagion effect, I think. Next slide. And so what we're saying here is that the clustering of suicides, you've seen that, and that as I said, the impact of suicides on other people is very important. That's why the press in places like Guam has decided not to play up suicides any longer, and that's a wise idea. There is in island belief, or at least in the belief of Chukis and people in Ponape, the notion that there's a haunting spirit of suicide that calls people. This is particularly true after a person has taken his own life, that other people come, or other spirits come and call out to others to imitate and do the same thing. And so you end up with a culture of suicide through these songs and stories and so forth, and you end up in a suicidal climate today. And that's what we're faced with now. Next slide, please. The psychodynamics of suicide. Maybe here I should point out the fact that this is based on, this is not just hearsay. This is not just a sample survey. This is 1,500 cases over a 50-year period of time. These are all the cases that we know of, maybe representing maybe 90, 95% of the cases there. Not based on reports, not based just on the data in the offices here, but based on interviews with people, continual interviews with people. So I am confident of the data. However, it might be interpreted. In many of the cases, in about 80% of the cases generally, it's the suicide, the occasion is a problem within the family. I've mentioned that before. Generally speaking, it's with somebody that you can't touch. In other words, problem with a younger brother, no problem. I can take care of that. You know, after all, I'm the older brother. I can say what I want to him. Problem with an older brother, not so easily taken care of. Problem with a parent, that's tough. Problem with, in the old days, somebody else from the community or somebody else in the family, the extended family, well, that too is something to be dealt with. So 80% of these problems, let's say 75%, were originated in the family, some kind of a difficulty in the family. About 20% of them, or a little less, because of a relationship between a man and a woman. It could be a guy and his wife. It could be the fellow and his girlfriend. But remember again that it was common enough for a man to react this way by taking his own life. It was very uncommon. It almost never happened that a woman would do the same because of the conflict. The strategy, the cultural strategy is one of withdrawal or distancing. The Chukis call it a munamun. That means if they don't like me, they don't accept me for who I am, I'll walk away. A munamun, making distance between you and the other persons. In the old days, it might have been going out in a canoe and sailing off to someplace or other, or just drifting off to someplace or other, or getting lost at sea. Now it's finding a tree, at least it was, and taking your own life there. But it was a separation of yourself and your family. Now, what a lot of people get wrong, and I'm saying this strongly because this has come up recently with a woman who was doing a dissertation on this. What a lot of people get wrong is saying that young people are holding suicide as a threat over the head of their family. Well, maybe this is intended. Maybe it is a threat. Maybe not consciously it is, but it certainly acts that way. But there's another dimension to this thing. The dimension is that the person who takes his own life sees himself as restoring himself, his own place in the family after his death. They'll put his picture on the mantelpiece. They'll honor the anniversary of his death. They'll cry for a while, lament his death, but essentially he'll be restored to the place that he had before. Now I know that this is a little difficult to swallow, but from talks with people, and from my own interviews with it, this seems to come up as a factor. Why else would a person choose a certain date that was important to the family? Why else would he hold in his hands a picture of his family and hang himself over the grave of his real brother? Something that I mentioned yesterday. Okay, next please. Now, the one thing that we have to remember here is that this is looking at little islands. Okay, these are remote places. This is the outer islands. This is the more traditional places. When we say more traditional places, we're talking about we're talking about Chuk atolls and Yap atolls, small atolls. Sort of Toby, Sansorol, that sort of thing. The rates, these are comparative rates here. And you can see that the Chuk atolls and the Yap atolls were, Yap atolls are considerably higher, but are much, much lower than the state itself. What that tells us is that traditional places at that time tended to be immune from the suicide problem or not as affected by it as places that were more modernized. Next. So, just looking over the elements of the social explanation here. The data on the rising rates shows that the suicide is epidemic as well as endemic. We've seen that, in the clusters. The low rates in the outer islands suggest that problems arise from modernization. What problems would they be? We'll go into that in a minute. The suicide rates began increasing in the late 60s as social change intensified. Yes, it did. We all know this, and we all know why. And suicide springs from the family. Perhaps the family is key to understanding the problem. Now, this is not data. These are conclusions that either come from data, or in the last case, perhaps the family is key to understanding the problem. A theory, a hypothesis that comes from this. Next. So what was the change? Well, the other day, yesterday again, to refer to that, I mentioned that the islands changed considerably during the 1960s. The 1950s was keep the good old days alive. The 1960s was President Kennedy comes in, the subsidy increases, criticisms of the trust territory grow, and to prove ourselves we have to modernize rather quickly. And so you've got the U.S. subsidy grants increasing from 1960 there up to 1978. In 1 year alone, the budget doubled. Over that period of time, you can see that the budget for the trust territory increased from about 7 million, I think it was, 6 or 7 million a year, to something like in the area of 120 million. So this was a rapid increase. So what? Money doesn't cause suicide, does it? No, you need a couple other factors in there. And so next slide. And so what you have now is more people working for a living. Not for a small amount of money, just 25 cents or 50 cents. No, that's right. Yeah, an hour, as it was originally in the 50s. But considerably more than that. So more people working, earning more money. You can see how this is a Micronesian employees grew over that period of time. And what that meant was people were bringing in money independently. What you have to remember is what I said yesterday. The guy coming back with his paycheck. bringing his paycheck, offering it to for the man who was in charge of the extended family and saying, here's the money, you know, just like food, I offer it to you. And then eventually the guy in charge of the extended family, the wife's older brother, says, no, 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 you keep that, you earned that, that's yours. And then the change starts. The fragmentation of the family, the breakup of the larger group, the breakup of the complex of people that was supposed to take care of the kid, the turning away of other members of the family, the extended family, and saying, hey, this is your child, you take care of your child, huh? And eventually abdication of the kind of traditional responsibilities that they had. And what I said yesterday was, and what I emphasize again today, is this was the safety net. This was a way of saying, this was a way of ensuring that if a kid got angry at his father, he had somebody else to go to. He had somebody else to go to who would sympathize with him, who would listen to him, address his concerns possibly, talk to his father, do all the kinds of things that he couldn't do himself. In other words, establish, to a minimal degree at least, this harmonious relationship within the family. Preserve that. But the family was changing, and this fragmentation was going on, and people were becoming, I think, more at risk of running into conflict, a conflict that wasn't easily resolved with other older members of the family. And that, remember, was responsible for 80% of the suicides over this period of time. Next, please. All right, it was 72%, not 80%, but you can see there the main pattern was these the problems that occurred before the suicide was prompted by a difficulty with a blood family member. But this is common throughout the Pacific. This is nothing new. It's just that it didn't occur. You had the safety net. You had the extended family. You had these people around to mitigate the anger or shame that could have occurred. I say shame. What I mean is the example I often use is this 11-year-old boy in Uman and Chuuk who threw a rock casually and hit the head of his uncle. And his uncle collapsed on the ground. It wasn't life-threatening or anything like this, but it was shameful. And a 10-year-old kid asks, well, who would I go to? How do I handle this? And because he's 10 years old and his judgment hasn't developed yet, he goes wandering off, hustling off into the mangrove swamp and hangs himself there. That's the kind of thing I'm talking about when I talk about shame. The minor pattern here is the quarrels that I mentioned with the wife or the lover. Never mind that found in the Marshalls thing in Palau, except that what I want to say is that it's more significant, the minor pattern is more significant in Palau and the Marshalls than it is in other places. So a greater percentage than perhaps just 20% might have occurred here. And then, of course, you get the emotions of jealousy or anger. Next, please. That was then. What about now? Now, I've gone over. I want to just take a moment or so. This has got that, what about now is going to be very short. But I want to take a moment or so just to see if there's any questions or any feedback. Yes. Yes. Please. Oh. Okay, he's coming over to.
What are some signs people may look for that may tell them that,
They may tell them
suicide,
what?
that someone's suicidal?
Oh, somebody isn't suicidal? Well, withdrawal, from family conversation, not being around very much, not perhaps seeking the even relationships outside of the family, certainly not talking to the school counselor, certainly not calling an anonymous number, not in the old days. You don't talk about family situations with other people. That is sensitive material. And this I can say, again, I presume that this is the same thing in Palau, but I can say that with strong conviction about Chuk and Pohnpei. So it's not as if they're going to express this, but you're right. It would be shown in other signs, smaller signs like that. This withdrawal, gradual withdrawal. The other thing is when people are committing suicide, they don't write little notes saying, goodbye, everybody, I'm sorry for, what they do is they show it in other ways. So that someone was saying just last night, there was somebody in the family who put on his new clothes, got a haircut, and all this prepared himself for his final death, and so there's things like that too. Or there was one person who jumped from Two Lovers Leap in Guam, who about a day or two before started giving away things. He gave away cash, he gave away his, some of his prized stuff, including his car, and people should have recognized, we got to watch this guy. But things like that.
Some of the work I've done, I'll ask someone if I feel they're suicidal. I'll ask them, how are you going to do it?
To tell if they're suicidal?
Yeah, because I find if you say things will get better, don't worry, that actually may annoy them more versus saying, how are you going to do it? You may be able to engage them then.
I don't know if there's any way. I've been a priest for 50 years, and I never ever talked to a suicide victim about that. Nobody ever came up to me and said, I'm thinking of taking my own life, or I'm having these difficulties with the family. I was also at Xavier High School for a long time, and all I had to do was work on hints, the kinds of things that we're talking about. I wasn't getting anybody saying, help me, direct cries like that. What I had to do was, all I learned to do gradually was sort of interpret these little signs, these cultural signs, and try to work with those things. But suicidal is something that, as I've mentioned here, suicidal is based on a perceived relationship with the people who count. And so, in some cases, and especially among young people, the relationship with the family might only be damaged for about a month or two, and this pushes them over the edge. In older people, it may take a longer time. But if they perceive that they're sort of at the bottom end of their family, their other brothers and sisters are getting all kinds of treatment that they can't expect themselves, then maybe this goes on for a year or two before they either see the situation improve or they take their own lives. That's all I can say.
And how often do you think alcohol may be related to it?
Alcohol is, let me give you a story. There was an outer islander in Guam whose wife or girlfriend was in Fiji. He wanted the girlfriend to come back to join him in, I think it was in Guam. Anyway, he talked to her one night on the phone, and he used every argument he could think of to try to get her back. His friends found him almost weeping afterwards, after the conversation had ended. And they said, come, have a drink. He had been having drinks before then. And he said, no, I've got to go. He left, and after that, he committed suicide. Did drinks cause the suicide? No, of course not. Did they help facilitate it? Did they add to the impulsivity? Did they do what youth does, make it more liable for him to take this drastic course of action that he might not have if he hadn't been impaired? I suppose you could say that. But I think that the alcohol is its own problem. I mean, it results in other things. Alcohol is used, let me just say this here. Alcohol is used in a way, young men, in a lot of places, to put them in a place where they can talk about their problems without worrying about, openly. Huh? Sometimes it aggravates the difficulties at the same time. Oops. Sorry. Okay. Now we'll go on to the. Okay. This I promise this will be quick. Okay. Recently, we're looking at the total suicides by age cohort. In the past, 1960, the first line there, you can see 1960 to 2006, you had over 50% of the suicides under the age of 20. In recent years, that has decreased to about 37, 38%. So the number of people committing impulsive suicides, the number of young people, has dropped everywhere. Suicide is now, if it remains a problem, it's a problem of slightly older people than it had been before. Next. Look at the suicides by gender. Look at the fact that, I said that there was 8%, of the females committing suicide, of the total suicides committed by females. Look at the figures for 2000, 2006, and 2007 to 2015. 16%, 13%, 12.9%. So just as suicide is occurring more frequently among older people, females are getting into the act also. Not anywhere near as frequently as males are, but still there is an increase in the percentage there. Next, please. The other thing is that the outer islands, we referred to that before. Here, Yap Outer Islands, you could see that the outer islands in between 1960 and 2006, the outer islands only had a 19% rate compared to Yap's 35% rate. But you can see what's happened in recent years, 2007 to 2015. The atoll rate is now 45%. It's higher than the Yap rate. What this means, to put it simply, is that places that are more traditional are now being more affected by suicide than they had been before, much more affected by suicide. We could put other data on there, to show the suicide rates among people who have gone to Guam, but that's for another day. Next, please. Palau suicide rates, and this is really the last graph. The Palau suicide rates, that gives you an idea of how suicide has gone, the suicide rates have gone in Palau. As I mentioned, Palau started off with relatively high rates compared to the rest of Micronesia. The rate was close to 15 even during the 1960s. And then there was the same kind of rise that you saw in other places, with a drop over this 5-year period of time in the late 80s, increase again, and then a drop. And now, in the last few years, there seems to be an increase in suicide again here. I said Palau was first and last, and this is what I mean, last. last place to, not the last place they have to deal with the problem, but the last place with high spikes. I mean, of course, Guam does too. What is going on now? Is that part of the old earthquake, or is this a new problem that we're beginning to see? And that's a question I think that we should keep our eyes open to, and our minds too. This is the kind of question that we have to deal with if we're going to make things better, more livable for young people today. So thanks for your patience. Sorry to go on so long, but as I say, this is just the beginning of the conversation. Keep thinking about it. Thank you.
Thank you again, Father Hiso, for your presentation. Folks, we have about 5 minutes until the next presentation. We were supposed to have a longer break. So everybody, please take a quick, maybe 3-minute bathroom break, stretch, and then come back for the 11 o'clock session, please. Thank you. Everyone, we are beginning our next presentation. Thank you. Our next topic is on universal health coverage, health financing, and this is presented to us by Luis Vinals Torres, who is the coordinator for the Health Policy and Service Design with the WHO Western Pacific Regional Office. Mr. Torres?
Good morning, colleagues. Good morning, friends from Palau. My name is Luis Vinals, and I have just been introduced and work in Manila at WHO Western Pacific Regional Office. The few slides that I have put together today, it's a bit to bring the relationship between health financing and universal health coverage. We all know that money is important. Money drives a lot of incentives and performance and has a lot of power. So we really want to make, to show what is the link between health financing and the policy goal that all of us wants to achieve for Palau, which is universal health coverage. So I'm going to have three main parts for the presentation. The first one is a bit to make this link, to explain what's the link between how the money flows within the health systems and the goal of reaching universal health coverage. I'm going to talk about the what, the why, and the how. The second part of the presentation will be about Palau. What is the progress of Palau and what we think that might be the issues of the Palau and broadly for the Pacific when we bring the health financing lines. The third part of the presentation is to try to stimulate some policy dialogue and policy considerations that Palau might want to look at when looking at the future. So very quickly, I'm sure you have been already exposed to this definition, but just to keep it at the back of our mind. Universal health coverage has two main parts. One is we want that everyone that needs health care gets it and quality. And we also want that when people access services are not getting poorer. So everybody in Palau can get the service that they need and they are not spending too much when accessing these services. So basically, these two things. In Palau and most largely also in the Pacific, what we have found from the regional office of WHO is that financial protection, meaning people do not have lots of financial problems when compared with other parts of the region when accessing services. But what we found, and I will show some data, is that there is gaps on utilization. So people need some services, but then they are not getting these services. It's issues of access, but issue of use. The pattern of use shows that some services, particularly on non-communicable disease, are not used as they should. So we have a gap there that we would like to address. And health financing might have a role. So when we assess progress towards universal health coverage, as my colleagues might have already covered, we look at these two arms. We want to measure that everybody is getting the service they need, but also that nobody's getting poorer to use when using health services. So there is three dimensions, and I'm sure you have been already seen the WHO cube, which we want everybody being covered. We want also that the services that matters are covered and that the cost of the services are covered. So that's the famous WHO cube, which is a graphic way to present what do we need for universal health coverage. So we want that everyone in Palau is covered by this, it's entitled to receive the services. So because Palau citizens or Palau residents, everybody is entitled, or Palau members of the social insurance, it's entitled. We also want that all the services are covered with the vaccinations, of course, but all the way up to cardiovascular diseases, treatments, renal failure conditions, etc., etc. And what we also want is when we are using these services, we are not having to use a lot of out-of-pocket money, not because it's free, because we have paid through taxes, we have paid with government money. So we have already paid, but we don't pay it twice, no? And when we pay this second time, when we use the services, it's not a lot compared to our family budget. So I was repeating, we want to utilize the services of quality and not getting organization. But also we have other objectives also. We have what we call in WHO intermediate, UHC, universal health coverage, intermediate objectives. For example, we want equity, meaning people living in Coror has to have the same access of services that people living in the islands down south. We also want efficiency. We want that when we are purchasing services to go in Taiwan or in Japan, we get good deals, we get good prices, and we get value for money of what we are purchasing. And also, we also want transparency and accountability. We want that our providers are taking care of the health of our population, so they feel responsible of keeping people healthy. We also want them to do health promotion to keep all of our citizens of Palau healthy. For that, we look at the left, at the far left of the slide. That's the functions of health financing. That's a bit technical, sorry for that. But basically, health financing includes the way how we generate money for the health systems, taxes, or our own pocket, or contributions to health insurance. You have savings accounts in Palau. So the way how we put the money in the savings account. You want also pooling, meaning you want that this money somehow goes together somewhere. I think in the case of Palau, is in the social, is in insurance and in the government. Because why do we want them together? We want the money together because then we pay the money for the people that need it. So it's kind of a subsidy, like all Palau citizens want to contribute in order that those that are sick get the services they need. So we want somewhere the money to be closer, to be together in some place. And we also want the purchasing function. So the way how this single purchaser, the government of Palau, pays, we want that gets the maximum value for our citizens and for our communities. Those are the three functions of health financing. And we want to do the three right because we want them to be equitable, efficient, and then to reach the final goal of everybody getting the services that they need without financial hardship. We are, in this summit, we are talking about inequities. So let's see where the problems start. The problems might start when public spending is inadequate. We don't have enough money to pay for the services that we need. We can also have problems when resources are not distributed fairly, among different population groups, among geographics. That's among type of conditions when we spend too much on the wrong thing, and we don't cover basic things which everybody should get. Might arise some inequity issue. Also, when access to care is based on ability to pay, that's not the case if my understanding is right in Palau, because you have a scheme that protects you. But in some countries, only the people that can afford get services. That's really a driver of inequities. And the last one is when decision making, the way this institution, the social health insurance and the government of Palau, when we distribute the money, if it's not based with the population needs, it might drive inequities. So we want to avoid these issues, and we want to make it right. So, okay, now let's look at Palau in concrete. What is the health financing progress, and the issues that we perceive might be an issue, and we have to keep a look there to make sure that we are keeping going in the right direction. So let us start with the good news. Palau has been increasing in terms of US dollars per capita for health, has been steadily increased for the last 2 decades. So we were around spending a bit above $600 per capita in around 2000, and now we are above 2,500. So we have the money available for health has been increased many times. So we have good news there. And if we look at our peers, we look at Pacific countries and we look at the Western Pacific region as a whole, we have that all the region has increased, but not at the speed of Palau. So good news to start. The second good news is the share of out-of-pocket spending has been decreasing. In health financing, out-of-pocket spending, which is the money that you have to move from out-of-pocket when you go to the pharmacy, or when you go to the hospital, or when you go to the health center, when you go to visit the doctor, the share of out-of-pocket, which is the enemy, actually, is the enemy of health financing, has been decreasing consistently in the last decade. Good news. Another good news. And then also we have some promising policies in Palau. Still good news. We have 100% population coverage of the medical savings account scheme, and we have 88% population coverage of the national health insurance. So we have only 12% of people that are not covered. Of course, we would like them to be there. And an important point on the saving medical accounts is in saving medical accounts, we are not pooling the resources. So basically, every citizen helps himself. So from WHO, our recommendation to countries is that everybody should help everyone. But the good news is that you have the national health insurance where this can happen. Another good news, in looking to your policies, is that you have allocated 10% of the alcohol and tobacco taxes for NCD prevention. So there is already a prioritization to try to change the lifestyle of our citizens and make it healthier and preventing and for avoiding the development of disease. So a lot of good news. Now let's look at perhaps not good news, but let's see where the challenges, where the threats might come in the future for Palau. Let's look first at sustainability. No, you have increased a lot the amount of money put to health, but this cannot increase indefinitely because it's an issue of affordability. The system might not afford to keep increasing the level of spending at the level that you have done in the past. So we have to look at, we will have enough money in the future to accommodate the needs because the back will not keep increasing always. So we need to recognize this challenge. Particularly because we have growing needs. We will have aging population with more NCDs and old age-related conditions. This would require more money. Remember that almost 2/3 of our spending, it happens in the last part of our life. So the more people we have above 65 years old, the more spending we need. And that's why the pooling of the money, putting all the money together, it's important because you want the young people, our sons and our daughters that are now working, wants to take care of you when you are going to require this treatment in the last years of your life. So we will have more growing needs, and we might not have the space, the physical space, the money, the government money with the level of speed that we have in the past. We also have rising medical costs, medical inflation, not only in Korea and in Palau as a whole, but when you go abroad to seek a specialist care, this is going to be more expensive. So you have a threat also there. So, and also the way how we access services also influence the price that we have. So we have to look at these four things to make sure that we can control these costs, that we have enough resources, and that we distribute them equitably. So let's look at the second part. We might have some underserved areas down the islands of the south in some remote areas, which they also are Palau citizens deserving the services that we want for everyone. No? So we have to look at whether we have to monitor these inequities and this package of services for every citizen in Palau and see whether everyone is getting the good. The second thing is we might need to look at the financial barriers linked to the way how our co-payments are made. So we are paying we have insurance for 88% of the population, but there is a percentage co-payment, which is a small, and this is an annual cap. But if you are a poor family, perhaps this annual cap it's too much for the family. So we perhaps need to look at whether the poorer families, this way where how we have designed the co-payment might be too much for them. So we have with the equity eyes, we might need to look at that. We need to look at the benefit package design. We are now considering, okay, can we afford hemodialysis? Can we afford cancer treatment? What is the right mix? Which is the way how we should be providing these services? That has a cost implication. No? And I think as a whole, for the entire society, we need to take decisions looking at everything, not every particular condition. But when we look at hemodialysis, we have to look at, okay, how are we spending overall? No? And then, of course, we need to keep monitoring, are we having very big difference on health outcomes in different population groups? Because then we need to take care of those population groups or vulnerabilities or particular conditions where we might not be doing a good job. Efficiency. We have to probably, from health financing, we might want to look at challenges in the procurement. No? We don't have a lot of purchasing power because we are a small set of islands. Now it's a country with population is not that big. So we cannot go and say, okay, I'm going to purchase a lot of services for a hospital in Taiwan because we are not going to have big volumes. How can we deal with that? We also want perhaps, to improve health promotion, to improve NCD coverages, screenings, but also treatment, putting people under control of diabetes. We might want to put some financial incentives for our frontline workers to take care of our populations at community level. But that's a potential of the health financing to increase these coverages. We also want to avoid fragmentation, and also we want the system responsiveness. An example, as I said, we want that our health workers, both in the hospital in core, but also down the line in the frontline service, they are taking care of our people, taking care of our community. So perhaps instead of waiting for the people to be sick, to have more of these healthy promotions, to be more monitoring how the health of our community are going. And this might, some financial incentives, in the way if we design it properly, can do that. Lastly, accountability. We really need to put numbers to help our decision making. And I am aware that the Ministry of Health is working hard for this to help. Last part of the presentation, key health financing policy considerations for the future. So let me again let's put a bit into the context. Now, after COVID, there is a bit of our most global recession. If we look at this graph from the World Bank, there was a big shock during the pandemic with a lot of countries with shrinking economies. Also, it's not the effect direct in Palau, but it's the indirect effect in Palau. If Palau without the students, we want Taiwan and Japanese to come diving, so we want them to get their economy recovering again, because that's it's going to indirectly benefit our economy. So we are a bit in a dire situation. So even the U.S. might not be in the same position that in the past to keep supporting the country. So we need to understand and acknowledge that perhaps all this beautiful trend of increase of spending will not be as good as we see in the past. So it's something we have to give them. So, but health financing, there is room to play and to mitigate the potential negative effects of this situation. We need to respond. So that's these 3 more slides. Very quickly. So key policy considerations for the future, to consider for the future. I think we have to, first thing is, let's if possible, continue increasing public spending. We have been doing a great job reducing out of pocket. Let's bring it a bit down. That's the enemy. Let's bring it to pocket down. And this it comes from public spending for health. We really want, there's a lot of decisions. We want to see whether we're getting value for money of the decisions, because there is efficiency gain. We can get extra money from the existing money if we can get cheaper options. No, let's look at, are we spending on the right things? Are we negotiating the medical referrals? Well, I'm sure that Palau has done a good job. Otherwise, you would not be with such good news. But is there any room for improvement? Third, let's look at the net needs. Now, because financial protection, we might do a relatively good job, I think. But then, what is the known unknown? So, what is the part of the system where we know that some things might not be well enough, and probably NCD's coverages might be there. How health financing can help improve that? It's not a health financing only business. It's everyone's business, and it's an HR thing, it's a monitoring thing, it's a medicines availability thing, but health financing can happen. Are we targeting amount of poor and rich? Should we look at the design of the copayment, of the shared copayment, in order to improve that? I'm not familiar with Palau system, but definitely it's something that I will pay attention to in my first visit if I was there. Last one, let's prioritize what are the right investments in the future. And I think let me make a case for primary health care. It's always cheaper and better for the communities and the citizens if we have a strong primary health care. We deal with the workload. We will struggle with sustainability of the system if everybody goes to the hospital in Palau. We will struggle. It's evidence from everywhere in the world. Let's strengthen the frontline services. Let's make our doctors also to support the Corona hospital doctors, support the frontline services. Let's build credibility of the frontline services, because you will have a more sustainable delivery. So, to finalize my presentations, I think one message important is not the Ministry of Health only business, it's not the Social Health Insurance business, it's not the Ministry of Finance business only, it's everybody's business. I think we want the role of the government decision makers. They are on the driving seat. They have the mandate to support and to take the decisions on behalf of every citizen in Palau. But also we want the healthcare fund manager. We want the ones that are having the decisions on which services should be prioritized. They should look at the data. They should have a broader consultation. They have been ways to listen to the users to look at what the cost effectiveness evidence public children have. We also want the hospital management teams looking at what can be a delivery model that supports their efficiency, sustainability, and quality of care. We also want the frontline health workers, those that are close to the community, to take decisions on and to support on how I'm going to reach this community there. How can I get this family, particularly in the remote area, that are not having a healthy lifestyle? How can I help them? This person might have diabetes. Can I bring him and put him on the treatment? We need the partners. You have partners. How can we help you? Bringing the evidence, state of the art from our places, but also understanding your context, not bringing solutions from elsewhere, but fitting the solutions to your context and your preferences, and working as a team to support Palau. And lastly, communities and citizens have an important role. You are co-responsible of your health. You also have to bring the voice for the decision making to make sure that they are efficient and keep their own sustainable. And with that, I finish my presentation. Thank you for this opportunity. It has been a pleasure. Happy to answer questions. Over.
Thank you, Mr. Torres, for your presentation. With us again is the Executive Director of PIHOA, Emi Chutaro, and she will be giving us our NCD update. Emi, thank you.
Ali, Yakwe, everybody. Pleasure to be up here again. I've been tasked to cover a very, very complex, complicated issue, and that is NCDs. And we've been hearing a lot about NCDs throughout this whole summit. And particularly during COVID, when we understood that a lot of our Pacific Islander populations were deeply impacted by COVID-19 because of NCD comorbidities. So we really have to address this issue in a very concerted way moving forward. So what I'm going to be doing is sort of covering sort of what we've been doing for the last 10 to 12 years, some data and some policy interventions that have been supported and discussed and implemented throughout the region, and kind of come to a conclusion whether we are actually going on the right track or whether we really need to rethink things very seriously moving forward and how to then go about doing that, and particularly from a health equity lens. So next slide, please. So I want to acknowledge the great vision of the then PIHO board president, Dr. Stevenson Corte, who convened the health leadership in May of in 2010, having looked at the data available at that time and said something is not right here. We are seeing a lot of impacts to our communities on these various diseases that we're seeing: diabetes, hypertension, heart disease, cancer, etc. So even back then, there was a recognition that this was a problem. And I also want to recognize Dr. Greg Dever here, who was actually part of that, part of PIHOA at that time, who also were having these very serious discussions. So in May of 2010, the health leadership of the time declared a regional state of NCD emergency. This was a very inaugural, pivotal decision that was made in consensus across the region. However, when we're talking about health equity, this declaration was already based on the principles of health equity. Because when we talk about NCDs, NCDs is a symptom of the larger environmental, political, social, economic, and personal individual life inequalities and inequities and disparities. So NCDs is a very good indicator of wellness and of health overall across our communities. This declaration had then led to a very serious series of discussions about, okay, what next? How are we going to do this? This is such a large and very complex, comprehensive problem. So a series of technical working groups were convened, pulling from folks from the islands as well as from our partners, to then draft a sort of a strategic framework for how we're going to sort of methodically and strategically address this very large and very complex issue across the region. So there are several parts to this, and I'm going to break it down throughout the presentation. I'm going to initially talk about sounding the alert. So the first thing was to say, this should not just stay in the health sector. It needs to be shared with our traditional leaders. It needs to be shared with our executive, legislative leadership. It needs to be shared with our international partners. And it needs to be shared with people even outside of the health sector within government as well. It needs to have a whole of society, whole of government approach. Next slide, please. So this is a very quick timeline of some of the key milestones that have been achieved over the last 10 to 12 years. So again, in 2010, the declaration was made and endorsed. It was then put up to the Pacific Island health ministers, which was also in the process of also doing a wider Pacific NCD declaration, but the Northern Pacific did it first. It was then put forward to the Association of Pacific Island Legislators, and it was endorsed by them as well. The Micronesian Islands Traditional Leaders Conference also endorsed it. And this was recognized both not only here in the Pacific, but in the World Health Assembly as well that occurred during that time. So this was, again, a very pivotal decision and declaration that the Pacific led for the world. So let's really note that the Pacific led this call. From there, then it was about getting down to work. How do we work together collaboratively? How do we integrate a lot of our abilities? How do we leverage each other's strengths to be able to address this? And so two interventions were decided as sort of key priorities for the region. First, let's really get our data right. Let's make sure that we have the types of data, the frequency of data, the accuracy of data that can really tell us where we're heading. Are our interventions working? Are they not? Where do we need to tweak? Where do we need to loop back and say, well, hang on, let's just change that because that's clearly not working. So it was really important at that time that we needed to sort of secure and have confidence in a series of data, priority data, that can inform ongoing work around NCD and to track whether we are being successful or not. The second intervention that was endorsed was to then look at policy interventions that have, at that time, evidence-based, and still to today, have strong evidence-based that actually influence positive changes in addressing lifestyle choices, et cetera, around NCDs. So these two I'm going to highlight a little bit more in this presentation. Next slide, please. So in 2012, a number of technical working groups from all the islands came together. Your folks who are surveillance people who were there at that time, you may remember being part of these technical working groups. Some of you had been reviewing this also as part of your ongoing surveillance planning work even to today. This framework was what was discussed and was endorsed as a region together. We couldn't cover every data set, and going back to Jesse's point, what is the point of collecting data when it's really not meaningful and it's not helping you to make the right decisions? So it's very clear that we're not talking about trying to collect every single data out there, but rather saying what are those very specific, important, critical data sets and information derived from that that will truly inform whether we're heading in the right direction. So what you see here was a very, very long series of conversations and debates, and this was the consensus that was reached. Since 2012 to today, this is the framework that has informed all the work that has been ongoing with each and every one of you here and across the islands in terms of surveillance planning, surveillance system strengthening, data collection, data analysis, and disseminating that data and information to our leadership and to our communities. Next slide, please. So this is an ongoing annual, biannual process depending on the jurisdiction and what they feel is appropriate for their needs. As of December 2020, where the islands are now needing to update their NCD monitoring and surveillance plans, aligned to that regional framework. And Palau, just congrats, thank you so much. You've updated your monitoring and surveillance plan, really excellent work. I know that took a lot of work to do that. Next slide, please. So in 2015, after the surveillance framework was endorsed, we needed to map out first what surveillance processes were in place, what data collection systems were in place at that time. Was it adequate enough to be able to collect the data both accurately as well as consistently? And where we were at in terms of that mapping in 2015, when you look across the region, there was a lot of reds. Never, 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 right? Some had been doing some stuff, but it was not done consistently. So for Palau in 2015, yes, you guys were doing youth surveys quite well. But in terms of addressing adult information. The last set was actually done back in 2003. Fast forward to 2022, you're seeing a huge transition of reds to greens. Awesome. Absolutely stupendous. This is a very simplified matrix, but the backbone of all the work that went behind that is absolutely tremendous. So where we are today is a testament to the hard work each and every one of you have done over the last 5 to 7 years, essentially. So for Palau, you're now all green. So excellent work. Congratulations. Next slide, please. In terms of the hybrid surveys, I want to touch on this one a little bit. As you know, we often hear in the islands, and again, going back to Jesse's point about survey fatigue, we had so many different surveys going on in the past. We had WHO STEPS, we had YRBS, we had, blah, 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 blah. And a lot of them were actually capturing very similar sets of information. So our 1 or 2 or 3 staffers who are out there trying to collect this data were having to do it multiple times, reporting it to multiple organizations for pretty much the same types of information that need to be sent out. So during these technical working group discussions and looking at the regional surveillance framework, there was a conscientious decision to say, okay, let's take a look at all of those reporting requirements, be it to CDC, WHO, HRSA, wherever, and let's look at some of the common threads across them, and let's look at potentially developing a new tool that actually can do a lot of that collection at one time. So rather than having to do multiple surveys, how can we look at hybridizing and combining some of that survey tool to be able to collect the same information that can then be reported out to different mechanisms. So this is the hybrid survey today. And again, Palau, just now, I know we started the planning in 2021 for the second round. It's every 5 years. But I think after this summit, we'll be ramping up then to do your second round of NCD hybrid surveys. So a lot of the data that we will be presenting today is actually coming from a lot of these hybrid surveys being implemented across the region. So next slide, please. So it's not just enough just to capture that data. It's not enough to write a report on that data. And as we all know, beautiful reports are out there, but they kind of have a tendency to sit on the shelf and gather a bit of dust. And when you really need it, then you go and grab it. No. So in the design of the regional surveillance framework, there was a very conscientious decision to say, how can we make sure that once this data is collected, this data gets into the hands of those that really need that information? Not only our health leadership, but also our community leadership. Other sectors who have a touch point around NCDs, let's bring them in. So every time that a survey is completed and the report is finalized and endorsed, then the next stage is then to disseminate some of the core data out of that with the communities at the national and state level. So every time that this has happened, stakeholders from the communities, leadership from the communities have been part of that process to hear, learn, discuss, and critically think about next steps moving forward around NCD response. So out of these data dissemination workshops, there has been input drawn in to identify some key actions that together, through that data, is identified. So data-driven decision-making, data-driven policy engagements. Oh, I guess I'm really short, sorry. Next slide, please. So this is another types of surveys that are out there, and again, Palau has been very consistent throughout these last 10, 12 years in doing these youth surveys very, very well with very, very good quality. So I just want to say kudos again to Palau. You guys have done a very tremendous job. Oops. Next slide, please. So let's bring all of that together, and what is our data saying? What is our data coming from your NCD program saying? What is the data from the surveys saying? And this is a simplistic view of a very, very complex set of data, but I hope it gives a bit of a quick idea of kind of where we're heading as a region and at individual jurisdiction level. So between 2010 and 2015, when we mapped out against a regional surveillance framework what data was available, and was that data comparable over time? Was it collected consistently over time? Was it using the same definitions over time that could be comparable from point to point? What was available at that time? So in 2015, when all of that work was done to review, clean, assess the data, what we're seeing is the table here on the left. I'm sorry, the colors are actually not coming out here, unfortunately, on the slides here. But green are these ones here. So if you look at Palau, the arrow down, that means that down is actually not saying worsening. It means that actually you're decreasing, for example, alcohol consumption amongst youth. So that's a good thing, right? So that's green. Reds are basically saying that the trends over time are actually getting worse. So things like increasing alcohol consumption amongst, for example, right? So that'll be a red. The zeros are basically saying from one point to the next, there was no statistically significant change in that indicator. And then the blanks were basically saying either there was no data, or the data was corrupted to the point that there was no confidence in being able to lead to a conclusion for that, or it was simply just one point in time when that data was collected. So there's no comparison that can be done over time. Fast forward to 2002, and wow, now we're starting to get more of those boxes filled. We're starting to get more and more of our islands being able to look at continuity of data collection, comparable data over time, and the confidence level to be able to then say with clear confidence whether it's a yes or a no, or are we improving, are we not improving, are we staying static, or are we still having issues with our data and there's no confidence that we can apply to it. So even though we still have some blanks here, we're getting there, significantly getting there. But what is this telling us? Going to Palau, we were having some improvements a little bit here and there, the indicators, particularly around, for example, adult BMIs. But when we then shift over to the next slide here, we're seeing now more and more knots, meaning there's been no statistically significant change in terms of some of these indicators. So either in terms of youth consumption of cigarettes, adult consumption of cigarettes, chewing tobacco amongst adults and youth, for example, and then in terms of diabetes, cancer, we're leveled out. Next slide, please. So I wanted to kind of break down one of those data sets for Palau in particular. For youth consumption of smoking tobacco, what was in that matrix was basically a zero, meaning there was no significant change for that. So for Palau, the baseline when this was happening was about 47% of youth had reported smoking tobacco. When assessed moving forward, 10 to 12 years moving forward, that had only changed by 246, or just basically a change of 0.2% lower. But really, when you look at it, it was not statistically significant change over time, and that's why it was a naught or a zero. 47%, 46% is absolutely astounding. that's almost half of our young people are reporting in these surveys that they are using tobacco, smoking tobacco. Next slide, please. Now, my apologies. We're still working on this. We are now taking a lot of that data, and we are transcribing them into Tableau, which is an interactive data dashboard software. And so far, we haven't gotten to Palau's data yet. So I wanted to show an example, though, of what we have been able to do for American Samoa, which is transcribing all of those data, providing the details of what that data is. And when you click on, let's say, a number or a particular link, it'll actually, you'll then actually be able to see the source data. You'll be able to see how the data was calculated, et cetera, et cetera. So we're hoping to be able to do that soon. And for Palau, I'm hoping before the end of the summer, we'll be able to have Palau's one. And it'll be posted on the Piho website. So all of the islands can be able to then to go to the Piho website, click on their own Tableau dashboard, and you'll be able to see all of that data in great detail. We still have to work some what we call data sharing agreements with our island leadership. So some of that data may be sensitive, so it might be locked. But for those islands that are okay to then share that in more public domain, those data cells will then be unlocked so that people can actually go in and click on that. Next slide, please. So I'm going to shift gears and talk a little bit more about the policy interventions that are also part of this regional effort. And the policy interventions followed a similar sort of modality of seeking consultations with a range of people from all the USAPIs, with our partners, looking at the science behind the evidence base of NCD policy interventions that have been proven to have a positive impact on lifestyle choices, particularly high risk of behavioral choices. So let's, next slide, please. So again, in April of 2012, after all those consults had taken place, the sort of the core consensus of what are some of the really, really vital policy interventions that will work and are appropriate to the Pacific region was agreed to and presented to the PIHOA leadership of the time. And this is the endorsed, what they call the commitment package for NCD policy interventions. So it's not every single policy intervention possibly out there, but it's really saying at a regional level, we in common agree that these are some of the key priority policy interventions that we need to be really focused on together as a region. So addressing one of the four major risk factors, tobacco consumption, alcohol consumption, nutrition, and physical activity. And within those four domains, very specific interventions were then also identified and agreed to. Next slide, please. So on the PIHOA website, we had worked a lot with the Cancer Council of the Pacific Islands. So you had heard from Martina Reichard and Dr. Neil Palafax yesterday about a lot of the work that they're doing through CCPI and under the support of the University of Hawaii John A. Burns School of Medicine. We had contracted them to help us transcribe and translate that NCD commitment package into some specific policy interventions, so how to. So there were some draft legislations that were developed, some examples of what, let's say, CNMI did. We posted it up there so that if American Samoa wanted to take a look at it, they could see what CNMI did and maybe transcribe some of that, or adapt that to American Samoa. So there was a lot of learning, a lot of sharing and dissemination that occurred during this time to make sure that it could be integrated and included into this NCD policy toolkit. Now, saying that still needs a bit of work. It's never done. There's still a lot of evidence that crops up. New NCD hybrid surveys are done. Other information comes in. New science, particularly now around COVID and NCDs, is coming up. Those are the kind of things that we need to continuously update and make sure that this is as cogent today in terms of policy toolkit and resources to help you all hopefully make your lives a little bit easier because some of that hard work has already been done. Saying that is not, not easy. Next slide, please. Now, in addition to this, we've been working a lot with our other Pacific Island colleagues, in particular the Pacific Community and also the World Health Organization, as well as, of course, the Fiji National University, CDC, and others. So this is a joint effort. There was agreement at the bigger, wider Pacific regional level that we need to also track these policy interventions more widely. So in 2015, the Pacific Heads of Health and then subsequently the Pacific Ministers of Health in that year had endorsed then the establishment of what they call the Monitoring Alliance for NCD Action, or MANA for short, which is hosted by the WHO, but it's a shared responsibility amongst some of the key partners. So in the Northern Pacific, I'm sorry, you can't really quite see that, but we've sort of divvied up, who is going to support whom in terms of doing these MANA updates. So PIHOA will be supporting the U.S. affiliate Pacific Islands. So this has been a pretty much more of a biannual, on average, process. We're now going into our second and third rounds of these MANA dashboards. Some are more, have been able to progress that more than others. But as of 2022, again, congratulations to Palau. You've done your next version of your MANA dashboard and have submitted that. I just wanted to say again, that was tremendous amount of work. Thank you so very much, and congratulations. So we're hoping that in the next, hopefully in the next few months, Guam and FSM will be done with theirs, and hopefully RMI will be the next one following them. Next slide, please. So where is this MANA information housed? So the Pacific Community has been very kind to integrate that into the Pacific Data Hub. So you can actually access that through the Pacific SPC portal. And I've provided the link here. But if we were then to scroll down and do the drop-down menu and pick Palau, based on the MANA dashboards that have been submitted, what we are here seeing now is from the 2017-2018 period, which is the left column. Here are the interventions, right? And then comparing that then to what is more recent, which is the 2020, and hopefully there'll be, once everything is submitted, that then we'll have a third column very soon. But look at this, my goodness. Lots of good greens here, which means that these are policies that are in place, they are being implemented, right? And the star systems that you see here is basically saying how much of a strength are those being implemented? Are they being implemented, but they're maybe having some issues with comprehensiveness or reach of that implementation? Maybe they might be having some issues around resourcing of that implementation, and so it might just be not as widely reached as others. But the fact that it's green in the first place is an excellent, excellent place to start. The yellows means that these policy areas, these legislative proposed legislations are still in draft. So they're working on it. They acknowledge that it's an issue, but it hasn't quite gone to the point where it's been passed, for example. The reds basically mean either it's not being addressed, or it's not a priority, or it's just not ready yet to get to that point, either because there's no political will towards it, or because there's still so much that has to be done in terms of advocacy to get it onto the legislative table. So in 2018, this is where we were at with Palau. There was great work already in place and done and implemented in terms of leadership and governance around NCDs. A lot of good work around tobacco. I know we have some folks here from the tobacco team. Palau has been really doing really well here. But there still were a few reds in terms of warnings, tobacco health warnings, and particularly on the industry commercial side. And then advertising, and then some food policies were still in the red in 2018. Fast forward, and a lot of those reds have now transitioned to either drafting stage or have already gone into implementation stage, where we still need to have, I think, some some conversations here in Palau is around food fiscal policies, still a red for both sides. Smoking cessation still needs a bit of work here. And, those two areas here. And then of course with maternity leaves, breastfeeding on the nutrition side, there's still quite a bit of work that needs to be done as well around trans fats. So this has been a very useful process to kind of say, hey, where do we need to still kind of tweak our efforts in terms of policy interventions? And I think what we've been seeing across all the US APIs has been a very steady improvement in this area. But now the hard work is where do we get to in terms of making sure that they're sustained, they're implemented, and that the whole of the community, our traditional leaders, our private sector, they're all in on this. They have a skin in the game in being a part, contributing to implementing these policies. Next slide, please. There's a sort of a subcomponent of work that is now happening starting this year, and that is around our vital statistics, vital registries. Across the board, we have been seeing quite a lot of challenges in terms of the accuracy of that data, the consistency of how that data is recorded, where it's recorded. And so we've been fortunate that this year we got some funding from CDC to convene a technical working group, a regional technical working group, to talk specifically about mapping out our vital statistics, vital registry systems. What are some of the gaps? What are some of the issues that we need to be addressing? And we're hoping that from that series of meetings, we can then develop a concept moving forward about how we can address this as a region and individually at the jurisdiction level. Because when we're talking about NCDs, we really need to know our mortality data a little bit more deeply and more accurately. Next slide, please. So 12 years on, okay, the data is telling us we still got a lot of work to do. On the policy side, we're making some critical improvements, but we're not there yet. So there was a decision to say, let's review this together. Let's take a look at this. How have we progressed after that declaration was made in 2010? So there is an external evaluation currently ongoing as we speak. Palau has already been completed, Sinai has been completed, Guam has been completed, RMI has been completed. Now we're just waiting on FSM and American Samoa to finish their consults to this. But we do have an external evaluator, Stellar, that has been contracted. They've been working on this for the last year and a half to do this very, very comprehensive work. And it's not just reaching out to our leadership, it's not just reaching out to our health officials, health agency staff, but also the communities, to NCD coalitions that are out there in the communities, all the different sectors that have touch points into NCDs, private sector, commercial, commercial entities, etc. So we are kind of nearing I would say the last quarter of this process. We're hoping to have some preliminary results available at our upcoming PIHO Executive Board meeting in April of this year, 2023. And we're hoping that that will be a jumping start to rebrand the next 10-year NCD declaration. It's unfortunate that we are not at a point that we can declare an end to NCDs, but rather we're at a point now to say NCDs is still a problem for us. Let's still declare an emergency crisis because it is still an emergency crisis. But let's rethink about how to do that differently for the next 10 years. So there is, next slide please, there is going to be a series of discussions over the next year and a half to rebrand a new and updated NCD emergency crisis declaration. I want to end to say that this is not doom and gloom. It's really about shifting then to thinking about health equity again, to think about wellness as a comprehensive approach to addressing NCDs. All of these that have been discussed today in this summit have been really wonderful and I think need to inform this ongoing process to address NCDs moving forward. I want to again, once more, and I feel like we've sort of done a little bit of a loop, Palau led the cause for the 2010 NCD Emergency Declaration. Palau has again stood up for the region and said that they will host the next NCD Law and Policy Summit. So thank you so much to Minister Farr, to President Whips, and all the other folks here in Palau who have continued to say that we will, that Palau will support this very critical effort for the region and be the lead. We're not sure yet when that is going to happen, but hopefully before the end of the year or early next year. And there's still quite a bit of work to do to mobilize sufficient resources to bring this NCD Law and Policy Summit together. Because it's not just going to be our health department folks. It's going to be our traditional leaders. It's going to be our business partners. It's going to be our local, regional, international, global partners. It's going to be everybody that has all different touch points to either support or be a barrier to people's lifestyle choices. So a really good example is transportation, right? The transportation industry here. Every one of us have been feeling the pain since COVID in terms of the supply chain for certain goods, particularly in some of our outer island settings, things like, you know, vegetables and fresh produce has been particularly impacted. So if we're not addressing the issue of transportation, particularly to our outer island settings, how can we then expect people to practice healthy lifestyle choices? So there are things that we don't normally think about, you know. So let's bring the transportation sector folks here and be like, hey, how can you guys be part of the solution, right? How can the businesses be part of the solution as well? And then last but not least, you know, I wanted to just congratulate each and every one of you here. NCDs is going to be with us for quite some time. We have to be resilient. We have to stay strong. We have to stay our true north. And that's not going to be easy. But that change ultimately starts with us. You and I here in this room. To eat, to live, to exercise, to be that person that is content with oneself, but has the confidence, the knowledge, the ability, and the access and the opportunity to then make healthy lifestyle choices. But it begins with us here individually today, and then starts today. So thank you all so much. Mr. Lang, I really appreciate your time. Thank you.
Thank you again, Amy, for your presentation. At this time, ladies and gentlemen, I would like to call upon one of the co-chairs for the Health Summit and Director of Public Health, Ms. Sherilyn Madraisao, to come up and give us her remarks. Director Sher.
Good morning or good afternoon. So I know I stand between you and lunch, so I'm going to try to make it short and sweet. I'm going to speak in Palauan and English as well. Kadamarmang raw labang lela program rigid, Health Summit rigid. Mang maldiswa kalom teera on behalf of the organizing committee for the first Health Summit. And so ma'am nga sulirar kami will adrabalu kami partners ra ma'am especially for your dedication, ma support ra kami, ma participation ra kami right kam lang mo 3 days. It's not very often kim convene na ma-close sa the olga ra kami adrabalu mail ko share and exchange sa experience ra gid ma koral all this with. So I wanted to thank our community partners for their efforts in the past 3 days and for their ongoing support to our work in improving health equity on a daily basis. So let's all give a big round of applause for our community partners. On behalf of the organizing committee, we wanted to express our deepest appreciation for our off-island speakers who travel all around the globe to be here. I wanted to recognize them and express our deep appreciation for their support in traveling on the other side of the globe to Palau to share their experience, their knowledge, and their expertise on equity. So everybody, let's please also give them a big round of applause for their support and effort. There's so many sponsors and donors that have made this event possible. So I wanted to recognize the U.S. Department of Health and Human Services. We have our other sponsor, MD Wholesale. I know PVA was also a support of the event. Many other local organizations, outside organizations, el direct tiram le supporter tel event regidrel al sils. I arrival last time na 3 days. So nga minister am le adura to the minister and I were talking this morning and we were sort of brainstorming what would be the next step from this. This will not be the last health summit. It's just the beginning of the exchange of dialogue, communications that we have with community partners, our outside partners. How do we move forward from here? How do we move forward in really embedding a health equity in all the things that we do? Ngraygal sa the community, Michael Cook environment settings to make sure equity is embedded in the work that we do on a daily basis. So our next step, Minister, we're going to be organizing town hall meetings and we'll be going out to the communities because each community have unique needs and we want to make sure that we understand what those community needs are and how we can work as a team to improve equity issues within the community. So the next thing that we will be doing is scheduling town halls meeting and we'll be going from one community to another community to really talk to them about issues that we see from the health side and then to also get an understanding of how they see issues sa community and how can we all work together to improve our health equity so that everybody ang fair and equal access to more services. So with that said, I'm really looking forward to work closely with our community health folks. And if you see, ladies and gentlemen, they're the ones sitting up front with the blue uniform. So let's give them a big round of applause too. Wanted to thank especially Dr. Dever and Dr. Darong for taking the lead in the community health worker. And I know this is our first cohort. We're looking forward to the second cohort and Miguel Restra cohort till afterward. So the komsulang arbek laad, but before I end, this wakal direkal ngutalte alle this was not an easy job. It took months of planning and, a lot of this agreement. But finally, at the end, we all had this consensus. Health equity is important and we need to put our heads together and make this a reality. So I wanted to also thank the organizing committee. Just to name our Tirigel chiefs, there were a lot of people who worked behind the scene to make this event successful. But I just wanted to recognize Adol, Madarnel, Olive, Everlyn, and all the staff. Tirigel will make this event possible all week. So if I may, let's give them a round of applause, the organizing committee for the summit. Finally, I just wanted to end the Liwase, Olangit Liwase, let us continue to work together. We rely on you, our partners, to help us move the needle, Ratokora health equity. So with that said, I just wanted to say thank you. And please, we still have a couple of sessions after my closing remarks. So this is not the end of it, but I know lunch is ready. So please enjoy your lunch, come back to the other sessions. Safe travels to all those partners who will be traveling tonight and tomorrow night. And thank you, and we wish to see you again in the next NCDC summit, which will probably be next year, up to Amy. But we hope to see you at the NCD summit, Palau. Thank you, ladies and gentlemen.
Thank you, Director Chair. Ladies and gentlemen, that officially concludes our summit. However, like she mentioned, there are afternoon sessions. Lunch is served. The sessions are at 1 o'clock. Transportations will be at the front, waiting to transport folks to the other venues. Please come back at 3 o'clock, where we will have more raffle drawings. Remember, we have the grand prize of a round-trip ticket to either Guam or the Philippines. And we also have another session at 3:30. Please come back for those. Thank you and enjoy your lunch. And one more reminder, if you're interested in the hospital tour, please sign up at the registration table for that. That tour will happen at 4 p.m. today. Thank you. Yes, another announcement. All the presentations will be posted on the website, palauhealthsummit.com. Okay, so those presentations will be available at the website. Thank you. Made available online after the summit. Thank you. Again, we ask you to kindly please complete and submit your evaluation forms that will help us for better planning for the next one. Thank you. Yes. Hard copies of the evaluation forms, if completed, you can submit at the registration table. Thank you. Okay, I'm told there are snacks available. If you guys want a snack, please grab yourself some. We are going to go ahead and do some raffle drawing prizes, giveaways.
Please take out your raffle tickets. The first prize will be a backpack that includes a calculator, a tape dispenser, first aid kit, and a $20. The lucky number is 669-552. 669-552. Do we have a winner? 552? Yay! Okay, the next prize is also a backpack that includes a calculator, a tape dispenser, a first aid kit, and a $20. The number is 669-325. 325. 325. 325. From PCC Tangkle, Choi Mascardo, okay. Tell her to claim her prize when she comes. Choi Mascardo. Okay, the next prize is a backpack with a calculator and a $20. The lucky number is 669-321. 321. 321. Have any? Nothing. Three 9-3. Yes. The next prize is a calculator and a tape dispenser. The lucky number is 669-469. 469. 469. Okay, next. Shuffle. Okay, here's the second number, 669-408. 408. 669-408. Yes, please head to the station MD Wholesale and claim your prize. The next prize will be a Blink camera. Six six nine 478 478. 669 478. Yes, congratulations. Yay. Next prize will be a Samsung tablet. Okay, this number is 669 563. 563. Okay. Congratulations. Next prize is a cash prize of $50. 669 455 455. $50. Namaral. 669 539 539. $50. 539 539. Okay, next. 669 543 543. 543. $50. 543. No one? Next. Six six nine 301 301 301. $50. 301. Okay, next. Okay, 669 472 472. I hear someone. Did someone? Oh. Oh, okay. No one with the number 472 for the $50? Okay, next. Nothing. Okay, next number, still the $50. 510 669 510 510. Yes, we have a winner. Next prize is a $100 bill. Oh, yeah, sure. $100 bill. 669 406 406. Yay! The next prize will also be $100. 669 464 464 464 464. Next. 669-441. 441. $100 bill. Yay! Okay, the next prize will also be the $100 bill and the last $100. $669-434. 434. Yay! You have a lot of winners. Okay, the next prize will be a Canon printer. Okay, 669-308. Gegi Baye. Yay! Congrats! That'll be the last prize, and we'll announce the round trip ticket winner in a few minutes. So lang.
Congratulations to all the raffle drawing winners. Folks, we have a couple of minutes before our next session. Feel free to network amongst yourselves. The grand prize will be drawn after our next session. The grand prize again is the round trip ticket to either Guam or the Philippines, courtesy of MD Wholesales. Okay, so that will be drawn and given away after our next session. Thank you. Our next session will be at 3:30. Reminder again, all presentations and speeches from the summit will be made available after it's all finished, after the summit. Okay, just an update on the grand prize. It's a round trip ticket to either the Philippines, Guam, or Taiwan. Yes. Thank you, MD Wholesales. Also, if you haven't done so yet, please complete and submit your evaluations either online or fill out a hard copy and submit it the registration table. Also, the tour of the hospital will be the van will depart around 4 p.m. just outside. So those who signed up, please make your way after the next session to those vans for the tour. Thank you. Once again, ladies and gentlemen, good afternoon. Our next panel is going to give us an overall COVID response. This panel will be facilitated by Reader Uduy, and she will be giving us short introductions of maybe herself and the rest of the panel. Reader, please.
Ali, hello, and good afternoon. Welcome to the panel of overall COVID response. I know it's been a long 3 days. It's been an even longer probably day, and everyone is getting ready to hit the town. But if I can ask for 30 more minutes of your time. Before we begin our panel discussion, and let me just preface by saying that we won't have a lot of slides because it's all about storytelling. Yeah? So we're just going to be telling the story that happened in the past 3 years. So, but before we begin, we have some $10 airtimes that we want to give away to people that are here. But you have to answer a question correctly in order to get the airtime. So we'll start off with one question. This is a two-part question. You have to have both answers correctly. And all the questions relate to our COVID response. And hopefully you had listened or you were here for Drs. Adalbay and Darong's presentation, or your presentation about the Omicron experience. Because the response to this question was included in their presentation. Okay, so if you know the answer, just raise your hand and Gasti can help bring you the mic for your answer. So the first question is, who was the first to receive the COVID-19 vaccine in Palau? And the second part to the question is, why was that person chosen? So you have to raise your hand. Kastin tamle ko tol dars. Who's the first? Oh, okay, Gagit. Okay, so only two parts, so you have to have answers to both part of the question. Number one, tamle nguwa sel hotel dosa vaccine ra blue belau engara ul manggel ada milngil tumular seguidel first dose. Cabo.
Dr. Osar, intindim la kalaw ay silwa siya raw.
Okay, Dr. Osar. So I guess she gets $5 of the airtime, right? Tasabel help pernil answer sel second part yung sel other half ra airtime. Gay gidil nga ra end.
Milaringil lang mong other homebound, bengi homebound. For the whole population.
Okay.
And you get all the airtime.
Okay. Miss Sulang. So yes, the airtime amorang kang luwania di mo miss ka airtime. Kamsular say gidel answer. Dr. Osar amral ngilusel. She is received the first dose of the vaccine. Lebato ka reasons why. So number one, she is a healthcare worker. So she's one of the first criteria wasn't eligible for vaccine. She's a healthcare worker. She wasn't get our elderly geriatric program. So tirigidam the vulnerable population. So toktang our team protect our clients. And then SL number 3, direct ngar age group plus the conditions hindi ka daw ay conditions, but meet tiger role criteria ulamang lo gagidam lo usay the first dose of vaccine. Okay, so kamsula rokoy. Let's begin. To begin the panel, I'll introduce Tirakal partners rigid lobangedar el alsils. So ngaringi Singewo France. Singewo is the Disaster Response Officer for the National Emergency Management Office. Represent Rigidel Ngaranemo. Ngaringi Peter Paloy, nga Director sa Bureau of Aviation. Andira nga Director Ismail Agon, nga Director sa Bureau of Public Safety, nga Ministry of Justice. Direkal nga Ministry of Finance, ngaringingele Chief Charnel Sumang, Property and Supply Division. Ndira kal ngaringa Olgaril Kazuo, nga Performance Management Specialist, la Ministry of Finance. Ingayidil gakarel ngas karedil ngaraen da Michelle Ueda, nge Health and Social Services Coordinator ngara Palau Red Cross Society. So, Sherry, can I have my slides? So, seragim tial panel rigi da ko adil ol telwase ngira del altmar we have to build partnerships, and then in the event nga happen ngira we have to partner with each other to achieve our goal. So the past 3 years, what I've come to appreciate is that partnership is key. It's critical that we work together collectively to achieve our desired objective or goal. So next. So for the timeline, COVID, we all know it was in January of 2020, it was identified, and then January 22 of 2020, MOH, Ministry of Health, held its first meeting with the National Emergency Committee. I got dakpok to go through each and every one, and tingnan milestones in red, also I'll emphasize. So in January 28 of 2020, is the Presidential Executive Order 433, suspend flights from mainland China, Macau, and Hong Kong. At that time, the Ministry of Health took over the screening at the ports of entry, airport, the Masi Port, implement their health declaration form. Ndirakal sera January 30th of 2020, WHO declared 2019 nCoV as a public health emergency of international concern. With that said, we implemented the travel restrictions. So say February 13, Executive Order 436, extend the travel restrictions until March 21, restrict the entry to cruise ships. But even before that, stop the flights. And then February 19th, the first PUR. I think everyone remembers that time. Malmlekloadak travelue. Sera, next slide. Sera March 20, 2020, ngaring del second PUR. Gemlanya travel history from Guam. Sera April 1st of 2020, we received our PCR testing equipments and test kits from Taiwan. We'll build up our local capacity to test. Before then, I get two PUIs. We had to send specimens of island for confirmation. So say that April 4th, second PUI, our test results are negative. So those two PUIs, they were negative. And then on April 14th, we were able to test for COVID-19. Say that April 29, and we Executive Order 440, extend the travel and flight restrictions until June of that year. We started working, so when we closed the borders, so we closed the borders in March, so there were no flights coming in. We were able to bring in our patients that were off island, who were stranded, through chartered flights. And then we worked towards repatriating our residents. So in May of that year, we came up with what we call the Palau model, where we quarantined individuals prior to their arrival in Palau for 14 days with a variety of tests, like multiple tests. And then when they came on island, they had to go through another 14-day quarantine period. So next slide. So segi dira May 28 of 2020, there were 50 Palauan residents that went into quarantine Baluraquam for the 14 days. Throughout the quarantine period, 3 persons opted out of the quarantine. So when they did arrive in Palau on June 12th, after multiple negative COVID test results, there were only 47. But the day before, in Laringar, 11 Palauan residents that arrived from Taiwan. They also had to go through quarantine period in Taiwan before they came to Palau. So all of their day 7 tests while they were in quarantine, they were all negative. And then on July 3rd of 2020, they were all released from quarantine with negative test results. 58, so the 47 from Guam, and then the 11 from Taiwan. July 16th, 84 Palau residents and citizens entered quarantine again in Guam for an additional 14 days. So on July 21st, they all tested, and 2 of them were positive. July 31st, when they came to Palau, there was only 81. So out of 84, 2 tested positive, 1 was a close contact, 81 na may Balur. So I just share this timeline because Algora Professor Tegidal discussion ergid partnership Ministry of Health and Human Services with all of our local agencies, our local response partners in conducting the quarantine. Next slide. Okay, sorry. So tigidamle ICS structure for the repatriation. Our incident commander was Director of Public Health, Sherilyn Madraisao. Our deputy incident commander was Waymen Tuay, National Emergency Management Office. So you can see the circle, the boxes represent the tiral partners a panel al sales. So I'll give them each like 3 minutes each to share their story, to share their experience. What was their role during the past 3 years COVID response Blue Belaw. So we'll start off with Nemo.
Masulang Erite, good afternoon everyone. Before I go to specifically the role of Nemo, just because I'm from Nemo, we house the NEC, and so I'm just going to give a short overview or the overall response by the NEC. For those of you who don't know the NEC, that's the National Emergency Committee. So the overall response, I think everything went well. Even though it did not go to the level that the Ministry of Health wanted it to be, we still operated based on the National Disaster Risk Framework, and that is basically an all-hazard framework. And so everything's the same. The line of communication, the arrangements, the roles are the same. Just as the same as we are responding to a typhoon. But this time, it was a public health emergency. So the Ministry of Health took the lead. And all the NEC members were supporting the Ministry of Health. And to go on to the transportation aspect of the repatriation flight, the first flight, I can say that I think that was the most challenging aspect of the response I mean, we can see the NEC in the National Emergency Operations Center debating on whether or not to allow the flight to come or not. But even though all else, even though we, wait, I have to look at my notes.
Yes, so Singawa.
Yeah, it's been like how many years ago, so I.
Yeah, so maybe you can share what was kuramle major lesson learned from your perspective ranemo ngara kuramle area of improvement, selwa major area of improvement, and then moving forward there are recommendation.
Okay, so major improvements on the transportation side of the logistics aspect of the response.